حياكم الله أيها الأحبة والكرام معانا في دورة مشكلات الاطعام والبلع. هذه لأول مرة إن شاء الله تستوي على مستوى المركز، والأخت دورة فرانشيسكا ماريا بلوم أصلا أخصائية نطق ولغة وأخصائية مشكلات البلع. حياكم الله أيها الأحبة والكرام معانا في دورة مشكلات الاطعام والبلع. هذه لأول مرة إن شاء الله تستوي على مستوى المركز، والأخت دورة فرانشيسكا ماريا بلوم أول مرة تجي دولة قطر. طبعا هي هولندية وأصلا أخصائية نطق ولغة وأخصائية مشكلات البلع. تخرجت من أنتورب يونيفرسيتي في بلجيوم في بلجيكا، ومن 1981 مارست هذا العمل. طبعا مسار الNDT بوبث بدته في تسالونيكي في اليونان، وما زالت تعيش هناك إلى الآن. وبدت في هذا يعني من البداية إلى أن أسست ومع الجامعات والمستشفى اللي موجودة هناك، مستشفى الأطفال، وكذلك الآن تعمل في عيادة خاصة، ومستكمل المشوار مع الجامعة ومع المستشفى. هي لأول مرة في دولة قطر فنحييها معنا. الكورس الكورس مضغوط جدا، يعني هو لمدة يومين وفي فترة بسيطة جدا، فالرجاء يعني اتباع الجدول بحذافيره، خاصة أوقات الاستراحة. يعني مهمة جدا لأن في سيشنز بتكون عملية، يعني راح نجيب الأطفال ونعمل وياهم، فمهم جدا نحن نلتزم بالجدول. هذا الشيء الأول. الشيء الثاني، أحب أولا وأخيرا يعني طبعا أني أشكر كل اللي سهلوا هذا العمل، يعني من البداية، من أول ما بدينا أول سلسلة بوبث في العلاج الطبيعي وعديناها بشكل كامل. تعبنا شوية في البداية يعني أشكر من عمل معنا وهو موجود معنا الآن، الدكتور ذيب بني عودة. طبعا بدءا برؤساء الأقسام عندي، رئيسة القسم التأهيلي الأستاذة زينب عبد الله كمال، وعندنا كذلك رئيسة القسم الطبي كانت معنا كذلك في التأهيلي الأستاذة شيخة محمد، تحية لها، وجميع رؤساء وحداتي اللي أنا أفخر بهم. طبعا بدءا بالنطق واللغة عندنا الأستاذة نورة السليطي، في عندنا كذلك الأستاذة حصة المرزوقي في العلاج الوظيفي، وكذلك عندنا رئيسة وحدة العلاج الطبيعي الأستاذة أمل البلوشي، وعندنا رئيسة وحدة العيادات الطبية الأستاذة عاشي ياسين، عندنا رئيسة قسم التغذية الأستاذة شيماء، وكل الاستاف اللي تحتهم اللي عملوا تحتهم. الحقيقة يعني ما أقدر أعددهم كلهم، لكن كلهم يعني ما قصروا معنا، كان لهم الأثر، سواء كان شيء إداري أو شيء علمي أو بحث معين. أذكر منهم من ساعدنا فنيا في ذلك الأستاذ أحمد شديد والأستاذ أحمد عازم، وكذلك في النقاط عندنا النقاط CPD الأستاذ أحمد باطة، اللي قام بتحديد هذه النقاط CPD points مع وزارة الصحة، وهي 10 نقاط لهذه المحاضرة. أي تفاصيل بالنسبة للنقاط راح يجاوبكم عليها إن شاء الله في خلال الفترات، عشان ما نبي نقطع الآن، في خلال فترات الاستراحة وما بعد ذلك، ونخلي له وقت إن شاء الله يجيب على مسألة نقاط الترخيص لهذا. في شهادات حضور كذلك للي جايين من خارج المركز، أحب أرحب فيهم. في عندنا أخصائي من مركز النور المكفوفين، ارحب فيهم، ارحب في جميع اولياء الامور اللي جايين معنا اليوم واللي حاضرين معنا، سواء من منتسبين داخل المركز، وكذلك عندنا من مؤسسة حمد الطبية ومؤسسة الرمية للتأهيل، كذلك مركز التأهيل وإعادة التأهيل، أحييهم معنا إذا كانوا موجودين. وأحيي الجميع وكل من لم أذكره، يعني وخاصة الخدمات المساندة والعلاقات العامة والاتصال والإعلام، بدءا بطاقم الأستاذة نور المال وجميع العاملين في الإعلام معنا، وبدءا من تسهيل المدير التنفيذي بدورات مثل هذه من تدريب الكادر، وهذا يحسب للإدارة الحقيقة. وشكرا جزيلا، ما نحب نطول في المقدمة، نحب نبدأ إن شاء الله على طول مع الأستاذة دورة. تفضل.
It's okay? Okay. A very good morning. I'm so very pleased to be here. It's my first time in Qatar. I want to thank you for this very, very kind invitation. I want to thank all the colleagues that communicated with me through emails so very kindly. And okay, I had a very homely feeling communicating with them. So finally, yesterday I got to Qatar, and I really feel like being home. The culture I live in, the country I live in, Greece, I think has many things in common with Qatar. First thing is the sea. You have very close connection to the sea, so you are traveling people, and I mean traveling people, not only traveling from country to country, but also spiritually free people, people that think a lot, people that have a lot of ideas, people that are hospitable, that invite other people to learn from and to exchange ideas. So I really am very, very glad for this invitation and for this opportunity to meet you all and to work with you all. My name is Teodora Francisca Maria. Yes, that's true. You can call me Dore. This is my small name. I'm an SLP. I'm a speech language pathologist in Thessaloniki, Greece. Okay, my origin is Dutch. That's true. But I've been living and working in Greece for 35 years now. We have a small private clinic, but we are also connected to two big university hospitals in the city of Thessaloniki that has about 1.5 million inhabitants. It's a smaller city. Athens has 5 million inhabitants. We are connected with the neonatal intensive care unit of one of the hospitals, and the other hospital takes care about the cochlear implants of our children, so we are connected to them too. So today and tomorrow I want to talk about feeding difficulties in our children, in children with syndromes, children with CP, perhaps a little bit about prematurely born babies and their feeding problems. I understand that you have a big population of students and also a big amount of kids that really need our help in safely and pleasurably feeding. So let me open the presentation. I started with a big falcon because I think this is in your history. This is a very, very important bird for Qatar. We have them. I hear them every summer when we are in our beach house, especially in the evenings. You can hear them cry, and it's really a very precious image and a precious bird. So let's start with typical development. We never think about how we eat, how we drink, how we swallow, really. The only thing is that when you encounter a child or a baby with severe feeding problems, a baby that cannot even drink by mouth and that has to be fed with a nasogastric tube, then you start thinking about the complexity of these functions. So primary oral functions would be functions that are connected to eating and drinking and swallowing. We could say that secondary oral functions would be connected with speech and voice. We want to do many things with our mouth, not only feeding, but also speaking, singing, making voice. If you look at typical developments in babies, we can perceive a strong reflexive activity, a strong reaction on stimulation in or around the oral area. The oral area for a baby is the most important area. It's the area with which it discovers itself by putting the hands in the mouth, the feet in the mouth, all the toys in the mouth. So it not only discovers itself, but it discovers also the environment. The anatomy for a small child, for a baby, is very different from our anatomy. The mouth of a baby doesn't look like our mouth. It's much smaller, especially the mandibula. The lower jaw is much smaller. So this makes the oral cavity very small, and it looks as if the tongue really fills the oral cavity. There's also another big difference, that is a very big difference in swallowing, that is the larynx. The larynx, as you can see in this picture in a baby, is very, very small and very, very high up, okay? It's on the level of the first, second cervical spine. This means that a baby, when it swallows, doesn't have any laryngeal elevation, any laryngeal lift. Whereas our larynx, every time we swallow, even if we swallow our saliva, the larynx moves up and a little bit forward to be underneath the epiglottis. So swallowing, we could say, is a little bit more safe in babies. Suckling movements, we can already perceive them from the 14th week of pregnancy. And then after 1 month, the 18th week, approximately, okay, we can perceive swallowing of amniotic fluid in a baby. So this means that a baby, when it's born very, very well prepared. Especially the last month of pregnancy, the baby is swallowing about half the amount of amniotic liquid. So this means 400 milliliter. So this means that it drinks more inside mom than when it's born. Okay, so it comes to life very, very much prepared. So let's say that a baby is born prematurely. When it's a baby of 28 weeks, these are the ages that we can start inside the incubator to give a little bit of stimulation with fingers in the mouth or a pacifier in the mouth of a baby. A little bit of non-nutritive sucking on a pacifier could be practiced with a lot of care, of course. 34th, 35th week of a premature baby, this is the age of a very young baby in which it could start oral feeding. Before this age, oral feeding is mostly not possible, so the baby would need a nasogastric tube for food. So swallowing for a baby is something very different from our swallowing, right? We could never perform the movements a baby makes while bottle feeding or breastfeeding. It's a suck, a swallow, and a breath. Breathing, respiratory function is the fragile function for a baby. Very often here is the problem. When you are born with a minor or major brain damage, or when you're born with a huge prematurity, mostly the respiratory function is the function that is not ready. The lungs are not ready, are made ready by the high technology we have in neonatal intensive care units, of course. But respiratory function stays the very fragile function in the suck, swallow, and breathing combination that the baby has to perform. Feeding reflexes are very, very important. Palmomental reflex is a reflex connected to the palm of the hand of the baby. Hands of a baby are mostly closed, are always fisted. Yes, so a baby itself is stimulating the palm of the hand that has a connection with the mentalis muscle, the chin muscle. So little contractions of the chin muscle initiate swallowing. Rooting reflex is very important. A baby is searching for food from one side or the other, opens the mouth actively to receive the bottle and to take in food. And then when the bottle is inside its mouth, suck, swallow reflex and bite reflex take over. It's like a suction and a compression, decompression movement. Okay? And then there's also a reflex that is protective, which is called the gag reflex, and keeps out of the mouth of a newborn baby anything that is unwanted, like a little piece of cloth, a little hair, but not a pacifier or a bottle, because this is what it already knows. Baby has a hard drive, and it already had a hard drive when it was inside mom. So it was very well prepared for movements like sucking on your fingers, sucking on your little hands. So this is what is already archived and known for a baby. So never a gag reflex on any bottle drinking or breastfeeding. So my job in Thessaloniki is for, let's say, half of my working time working with very small babies. So this is what you observe in babies. You observe a suck, swallow, breath sequence, and then you observe a mature sucking pattern with 10 to 30 sucking movements in an entity, in a birth. A small pause just to get the oxygen saturation of the baby on a right level, and then again another 10 to 30 sucking movements. So sucking and swallowing for a baby not only is survival, not only is milk intake, but it also is the biggest possibly respiratory exercise. Physiotherapists ask me very often what to do with the respiration of this baby that has bronchopulmonary dysplasia. Yes, very often the case in kids with prematurity. And then I tell them, okay, 7-8 meals per day, 7-8 bottle feeds per day. When you do this properly and you do a little bit of pacing, you do the best possible respiratory exercise that you could ever give a baby. Spoon feeding. Spoon feeding is starting round about the 6th month. We have World Health Organization's guidelines that tell us 6 months of exclusive breastfeeding would be the best possible start for every baby. So after 6 months of exclusive breastfeeding, we could add a little something on a spoon for a baby, right? Cup drinking, adding cup drinking to breastfeeding and to bottle feeding is a very different function, is a function that needs quality, is a function that needs a proper sitting position for a baby. So mostly occurs around about the 7th, 8th, even 9th month of a baby. A baby really has to be able to control the head, to control the sitting position, to be able to drink from cups like we have here on the table. And then chewing. Chewing would be the last piece of the puzzle missing in eating and drinking for a baby. Is a transition to solid foods, to finger foods, to small amounts of chewable foods like a small piece of bread or a children's biscuit or a small piece of soft fruit or soft vegetable. This could start also around about 6, 7, 8 months. Depends on what parents desire for their babies. They could desire baby-led weaning, which is not going into blended food, but into very small pieces of soft cooked vegetables, right? Prerequisite is always a stable sitting position, which we have in typical development round about the 8th month. Then the baby is ready to have an independent sitting position. As I told you, anatomy of the oral area is very different for a baby, and is changing, is very much changed when a baby reaches the age of 10, 12 months. Through a lot of practice, through a lot of chewing, through using the mouth with a different, in a different way, not only for sucking, but also for talking. A baby starts to babble, starts to talk, starts to use the sounds of its mother language. So tongue is behind the teeth, gets much more space in the oral cavity, so it can be used for something else also. It can try different sounds and different vowels, different consonants in the mouth. Normal swallow, you would divide it into 3 stages, although a normal swallow is not a second. Right, it's less than a second, but we divide it into phases just to know in which phase the problem occurs. So one phase is the oral phase, another phase is the pharyngeal phase, and then we have the esophageal phase, right? Oral phase is a phase that is voluntary, that I can chew, I can have control over my movements, and then I move the bolus to the back. It comes to the mechanical receptors of the back of the pharynx, and then a swallowing reflex is elicited. This means that the bolus goes to the pharyngeal phase. A lot of doors are closing and opening during these phases, and then the food goes into the esophagus. We could see it like this. So this would be the oral phase. This is a preparatory phase in which the food is chewed, in which the food is prepared, in which the food is centered in the middle of our mouth, and then it's moved to the back. Okay, it comes into contact with the pharyngeal wall. This is the pharyngeal phase. Then the soft palate lifts, contracts, and closes of the nose. So we never have any food in our nose. This is very, very different for children, for instance, with a cleft palate. They cannot close off their nasal cavities, so very often they have a little bit of milk or a little bit of food coming to the nose. And then some other doors are closing, like epiglottis. You can see it at the end of the bolus, yes? Epiglottis closes over our trachea. The trachea is connected with our lungs. We wouldn't want any food entering the trachea. And then we have an upper sphincter of our esophagus that opens whenever food comes and whenever we push it right with our tongue. So normal swallow needs controlled movement, needs very controlled sequences, and is very safe if ever we have neuromuscular maturity, we have normal movements, we have typical development, and we have a good support of our gross motor function, right? And then food moves slowly, slowly into the esophagus. Hyoid bone is a very important structure, is a very small cartilage that is here, just underneath the base of our tongue. Especially in a video fluoroscopy or a modified barium swallowing study, we perceive the hyoid bone in order to see whenever the swallowing reflex is elicited. Okay, so I wanted to show you this first lecture about typical development of eating and drinking, and perhaps I will clear it for you with some videos. Okay, I have to be patient, I think. Close your eyes and listen. You don't have to see a baby drinking from a bottle. When you close your eyes and you listen to the sounds of a baby drinking, you can already know that this is typical development, right? It breathes, it has this normal breathing pattern. Every swallow, it breathes out, it has this exhalation. Okay. Many of our babies don't start this way, okay? They just drink and drink and drink and drink and drink and drink and then go into apnea, right? This is one of the big problem groups. Okay, so when you have a start like this, you start to fear food, you start to really fear drinking. And first spoon ever. Okay, this child is approximately 5.5 months, and it was given for the first time ever a spoon with a little bit of fruit puree. And you can see that this is perfect typical development. Okay, it's not eating like you and me, right? It's just the start. It's confusing the spoon a little bit for its bottle that it's very much used to. But it's quiet, it enjoys, and slowly, slowly, it will develop in a couple of weeks the function of using the spoon more properly. Okay, it's very, very interested in this new food. Okay, and then for chewing. These children are 9 months. Okay, they are trying some. This is some sweet bread. Okay, but food is all about playing. It's about the sensory play. It's about making little pieces, putting it in your mouth, taking it out of your mouth, being able to handle the food, being very pleased with the food, smelling it, tasting it. Okay, and then there is a lot of communication going on when children are eating. Okay, so this child is really playing with the food, and then suddenly something happens. She sees the bread on the kitchen table, and she will ask for it. She will ask for more, right? She points to the bread. Okay, that's the bread. Give me more. Okay, and then when you're triplets, they are the children of a very good friend of mine, physiotherapists. It's very nice to sit all of us around the table and to enjoy food, to play with food. Okay, it's very important that children have an opportunity to handle their food and to play with it by themselves. Okay, so I wanted to show you this because development for our children very often is quite different. Very often our children are afraid of food. They don't like to eat because it's for them it's something that is near to choking, something that is not friendly at all, something that is not giving them a lot of pleasure. So this is our big job. This is the job of therapists. This is not only my job as a speech therapist, but also the occupational therapists, the physiotherapists, and all the educators and the caretakers should know how to feed safely a child and how to give them pleasure and safety during feeding. Okay, so let's go on. So when we talk about pediatric dysphagia, we talk about feeding difficulties in different populations, and we have to be able to screen and evaluate the feeding problems. We have to make a clinical observation, an evaluation, an assessment, and then if we have a lot of danger signs, we have to be able to send the child to a modified barium swallowing study. and to have extra information about the safety of their swallow. First of all, if you ever get a child for feeding evaluation, you look at the face of the child. You look at the facial expression of the child. We have muscles in our face, the masseter muscle, the buccinator muscle. We have many, many muscles that are occupied with the facial expression, but also with eating and drinking and swallowing, right? So we look at the diversity versus stereotype expression about the ability of a child to adapt to, go from crying to laughing to a friendly face, versus limited expressions. We look at a child if it's able to communicate, or it's very drowsy, not alert at all, or on the contrary, very agitated. And of course, you look at a child checking the symmetry or asymmetry of a face, which is very, very important, which could lead to a conclusion of a facial paralysis or big problems. Next, we look at, especially if we evaluate babies, is feeding reflexes. Feeding reflexes are very, very important for a start in a baby. So when a baby is 1 month, 2 months, 3 months, these reflexes are supporting feeding. The rooting reflex, the suck swallowing reflex, the bite reflex, and the gag reflex are very, very strong. After 5-6 months, these feeding reflexes fade out, so they slowly move to higher quality movements. The problem is that for many of our kids with a possible brain damage or some other disturbances of their motor control, feeding reflexes stay on and on and on and on, and quality feeding cannot occur. There are many, many older kids that still have a rooting reflex or still suckle on their food and are not able to chew well, right? So a lot of feeding reflexes are interfering with higher quality movements. This is what you need to get from all parents or caretakers: an analysis of mealtime. So sit with them and interview them. What is the program of your child? What is it eating? How many meal times it has every day? What is the food consistency? What is the quantity? What is the temperature of the food? How long does it take you to feed your child? Many times moms will tell me, Dore, feeding is so difficult for me because I'm occupied with it all day. I'm feeding my child for 1 hour and the child didn't have enough. So it goes to sleep, wakes up, and is very, very hungry. And then it starts over and over again. And then very often parents will tell me, meal times are the most horrible times I would ever imagine with my child because I'm force feeding my child. I don't know how to feed it. And whenever I go to the pediatrician tells me, okay, your child is very low weight. You have to feed it. And then I don't know how, right? So these are the practical problems, the very big problems some families are encountering. So having an idea about the duration of the meals, the handling of the children during meal times, the position of the children during meal times, and the environment the child is eating in are valuable information to get to my intervention plan. And then, of course, I have to look into the oral cavity. Okay, we're not dentists, but we all know what a proper occlusion looks like, what a proper oral cavity looks like, what a proper anatomy of the oral cavity looks like, condition of the teeth, any caries, any orthodontic issues. A lot of our kids take medicine. A lot of our kids take anti-epileptic medicine, which is connected to a lot of oral problems. More saliva, more infections in the oral cavity, a very, how do I call this? Okay, I get Greek words in my mind. A very sensitive oral area, right? So we have to note that they are taking some special medicine. And then we do a very, very detailed description of all the structures, like jaw, like lips. Jaw is the first structure to be stable. It's the structure where we build our motor control of our oral cavity on, right? So jaw, lips in connection to muscle tone, function, range of motion. Is there drooling? Isn't there drooling? Okay, what is normal in drooling? All babies have a little bit of saliva loss, okay, but what is the norm? How is the jaw? How are the lips in rest position? Are they closed? Are they always open? Is the baby or child breathing through the mouth or through the nose? Is there symmetry in the jaw, symmetry in the lips? Another structure is the tongue. So we ask ourselves exactly the same things about the tongue, and you need to palpate, you need to see, you need to observe in function whether there is proper muscle tone, proper function, proper range of motion, proper rest position inside the mouth, symmetry of the tongue, limitations like a frenulum, a short frenulum. Short frenulum, posterior or anterior frenulum, could cause major drinking problems in a baby, right? This is the first thing you look at. This is the first thing you observe. A mom comes to you and says, okay, my baby cannot latch on, it's drinking, but it's tongue clicking. So what's the matter? First thing you look at is structure of the tongue, is frenulum, right? Because the solution is very, very easy. You do a very fine laser cut on the frenulum and problems are solved. Baby doesn't need any passive mobilization after a frenulum cut. The sucking on bottle or breastfeeding will be enough mobilization for the baby. And then we look, of course, at the shape of the tongue, the size of the tongue. Sometimes we say, especially in children with Down syndrome, that there is macroglossia, that there is a bigger tongue. But very often it is not a bigger tongue. It's the muscle tone of the tongue that is so very low that it seems as if the tongue is very, very big. That's why it's very often outside the border of the lips. Okay? All this information is put against a general developmental and medical history. So for sure we want the weight and the growth of a baby. Especially the first 2 years in a baby's life, pediatricians are interested in, okay, how much grams your baby took in the last week, in the last 2 weeks. This is their first question. It's priority number one. So we are the persons that provide families with a safe way of gaining weight, a safe and pleasurable way of eating and drinking. I want to tell you that there is another cultural connection between the people of Qatar and people in Greece. We have a culture of enjoying food all together, in having a coffee all together, in having a very nice meal with everything on the table and dining for hours and hours, right? This is what we want for our children, right? We want them to really be able to enjoy, to have, of course, proper weight gain, proper growth, but with pleasure and safety. And this is for sure something that we have to preserve for our children. So whenever we don't have safety for the child, a modified barium swallowing study could show us where the problem is. Okay, so you ask yourself, what are the red flags? What could we possibly detect in our evaluation? It can be many, many problems, like baby or child is nearly choking, is having respiratory problems, is having a wet voice, a very strange voice quality, is having major stress signs during feeding. A baby could never tell you, hey, Dore, stop, because I'm not able to swallow this milk. But I can read the stress signs of my baby. The baby is with wide open eyes, is stretching fingers and arms, it's getting very stiff, is arching to the back. So I can read the stress signs of a child. Is crying, is trying not to swallow, is trying to spit out the food, right? These are all signs of something is not right. So then is the time to really perform an objective study like a modified barium swallowing study. Oh, thank you very much. Okay, thank you. Okay, you will give me one little break. Okay, this is an old video. I'm sorry for the quality. But this young man is 18 years now. He's in the last year of his gymnasium, of his high school. Things were not so very easy for him when he was born. He was born 26 weeks. He had major respiratory problems. It was a baby with very severe BPD, bronchopulmonary dysplasia. This means that a part of your lungs are not working well, so you have to speed up your respiratory frequency, like 80 to 90 breaths per minute. This means that you're breathing very, very, very quick. Okay, and this breathing cannot be combined with normal bottle drinking or feeding behavior. So I want to show you what mom was trying to do with her son. He is 16 months in this picture. This is where I met them. And every feeding session for Spiros and his mom was like this. Okay, so his mom told me, okay, I want to go out of my house. Whenever it's feeding time, I feel so bad because, okay, he's not having a good time. I'm having a very bad time. I don't know what to do anymore. Okay, so this is a situation in which you say, okay, this mom, this family needs help, right? It's not a bad mom. It's an excellent mom. It's a mom that doesn't know what to do anymore. Okay, so that's where we come in. And when you really want to occupy yourself with feeding difficulties, it's a question of education. It's very, very simple. It's a question of starting and searching for the best possible education. This is what we all did. In our center, in our very, very tiny center in Thessaloniki, we are 5 speech therapists. 3 of us are Bobath trained, so we occupy ourselves with feeding difficulties, and we see many, many difficulties. In a very short talk we had together, you told me that you have a lot of kids with autism also, so here we have a lot of behavioral feeding problems also. Very often this is connected. Okay, Spiro's problem was, in the beginning, at the start, it was a technical problem, right? It was a problem of not knowing how to combine and synchronize respiratory function with swallowing function. But it ended up being a behavioral problem because Spiros was old enough to think, okay, this is horrible. I don't want any food anymore. This is causing me almost an apnea. This is causing me a choking behavior. So don't give me any. So every mealtime was horrible, not only for his mom, but also for the kids. So this is always a mixture of technical problems and behavioral problems. We have to evaluate what is the technical problem and how could we manage slowly the behavioral problem. And I have to tell you that behavioral problems are worse than technical issues. Okay? Technical issues can be handled with better position, with facilitation, with food alterations, but to really handle a behavioral problem in a child that doesn't want to eat anymore, oh, thank you very much, is much more difficult. Thank you. Now you have to answer a little question for me. It's about 17, 18 years ago that we started in Thessaloniki with modified barium swallowing studies. We had an excellent radiologist, and we still have him. It's the director of one of our hospitals, the radiology departments, that started VFSS, it was called, like video fluoroscopy swallowing studies at that time. It changed to modified barium swallowing studies because we use barium as a contrast agent. He started these studies for Greece and Cyprus, and he still is a leading doctor in this swallowing study. You have to tell me if you have it in your hospitals.
Yes, we have
Yes,
it in hospitals, but
of course.
and we do the same barium swallow and barium
Yes.
enema for the.
Okay.
We do the same.
Okay. Good. So, what is a barium swallowing study? Okay. When you see it for the first time, it's a little bit difficult. It's not easy to detect. You could play it in slow motion, so you get to know the study much better. But it's an X-ray imaging of the swallowing process, in real time. So, how it's very simple. In adults, you keep a protocol with certain foods. In babies and small children, you can use the food the baby or the child is eating. You mix it with barium, and you just need 1 or 2 swallows to see technically how the swallow is performed. Okay, so when is it we need a barium swallow? It's in the case of oral pharyngeal dysphagia or in the case of esophageal dysphagia. So it's in all those children that we say they are not safely swallowing, right? They have a huge technical issue in swallowing. I'm not sure if my child swallows and if all the quantity of its food goes into the esophagus. Perhaps there is aspiration. Perhaps there is silent aspiration. Some kids aspirate their food and we don't even notice on the outside. Perhaps when you have a trained eye, you see a small color change in a baby. You see some eyes opening and some tears in their eyes, okay? But you have to have a trained eye for this. So no need for modified barium swallowing studies would be whenever a child only has a problem in the oral phase. This can be detected from the outside by just clinical observation. Whenever the child will not benefit from this study, so whenever we have children with degenerative diseases like myopathies that are degenerating, and we have a child that is already with a gastrostomy, and we know that it will not be better, then of course we don't occupy ourselves with another study, with a modified barium swallowing study. Or whenever the eating disorder is really behavioral, like in autistic children that are picky eaters, problem eaters, they choose 2 or 3 things that they would like to eat and nothing else, right? This is not a technical swallowing issue, but this is more a behavioral issue linked to their autism. Clinical signs are many. First thing is the pulmonary signs. It's the signs you get from respiration. It's apnea, stridor, coughing, choking, recurrent pneumonias, infections of the lower airways, vocal signs like a wet quality of their voice, and color changes like cyanosis. GI tract, gastrointestinal, we can see weight loss, especially in the first 2 years of a child. To gain weight properly and to have a proper thriving is the number one, is top priority for all pediatricians. So weight loss in the first 2 years of age is horrible. We all know that many of our CP children have very, very low weight, are very often undernourished, right? This has huge consequences for their health, huge consequences for their motor performance, and huge consequences for their academic performances. If you are with extremely low weight, you don't have any immune system working, you don't have a gross motor system working, you don't have attention span, you don't have enough stamina to play and to communicate, right? And another thing is gastroesophageal reflux disease. Reflux in prematurely born babies is perhaps 95%. Yes, reflux in CP children, in children with deviance of muscle tone, is 50 to 75%. Right? So this is a huge GI factor that is connected to their esophagus, really, but reflux very often causes oropharyngeal dysphagia. Oral signs like drooling, a child is losing a lot of saliva, a child is dehydrated because it's losing a lot of saliva. A child is 4-year-old, 5-year-old, and suddenly loses a lot of saliva. It shouldn't, right? We produce more than 1 liter saliva every day. A child of 4 produces at least 600, 700 milliliter of saliva every day. So it should swallow all this amount of saliva. When we have kids that have wet chins, that have wet clothes, that have saliva on their hands, so very severe drooling, this means not only that they have a swallowing problem, but also that they could have a problem with their proper hydration. We all know that to stay hydrated is much more important than to stay nourished. So it's one of the reasons of that we should pay attention to this sign. Children that are denying their food, like little Spiros, he was trying to spit out his food because he's afraid, right? He has an aversion against swallowing, against food. Extreme duration of meal times. Moms tell you that, okay, we're feeding for more than an hour. A quarter of an hour, 20 minutes would be a normal duration of a meal time, not more. Many of our CP children are so low weight because their food intake in terms of quantity, in terms of calories, is less than the extreme effort they use in eating. So if you are eating for 1 hour and you use a lot of effort in eating, you use more calories than the food you have on your table, right? That's why our children very often don't have weight gain and they have failure to thrive. Or any other oral motor dysfunction, dysfunction of tongue, of lips, of jaw, of chewing, right? Diseases that are linked to dysphagia are the biggest group of our patients, of our clients, are neurological patients, right? Are the group of children with brain damage, is the very big group of children with CP, with cerebral palsy. Another big group of kids with feeding problems are kids with syndromes, like children with Down syndrome. They almost always have a difficult start in feeding. children with Prader-Willi. There is a controversy because when they get older, they like food too much, but when they're babies, they are hardly able to feed because of their hypotonicity. Another group of children are the babies with myopathy, or children with myopathy, or children that develop myopathy. Very often they lose the ability of proper swallowing, of proper chewing. Then there is a very big group of new clients. We have the last 10 years, let's say, a population of extreme premature babies. We have babies in the age of 23 weeks that have a good chance of survival, but that very, very often have fragile respiratory system, and respiratory system with swallowing function are brother and sister. So kids with bronchopulmonary dysplasia, with respiratory distress syndrome, very often have feeding problems, swallowing problems. Prematurity, low birth weight, extreme low birth weight, small fordate babies are a specific group of clients nowadays. There are many, many babies that start off eating with a nasogastric tube that have to be rehabilitated onto towards oral feeding. Very often this goes very smoothly, but in some babies this causes great problems. Anatomical factors, babies with cleft palate, Pierre-Robin syndrome, is also a very special group of babies that not necessarily need to have many, many feeding problems, but you have to know what to do. Okay, put these children more in an upright position, choose your tools that you use for feeding well, so they won't have any problems. The environment of an MBS study is very friendly. Very often the parents are present, or the caretakers are present, or therapists are present during the examination. So the child is used to these caretakers or therapists or parents, and cooperation is quite friendly. You can use a car seat for small babies or small children, like you see here in the picture. And the examination okay, so I will show you a typical swallow, a normal swallow, and of course this is performed by an adult. We could never ask a child to undergo so much X-ray. Okay, so this is what the swallow looks like, and this is flexible endoscopy. Okay, this is going with an endoscope through your nose, looking at the trachea. Really, we can see the vocal folds, right? We can see epiglottis, and this is the way into the trachea, and here in the back would be the esophagus. Okay, so here we can see vocal folds. They're very nice and white. This is the opening towards the trachea. Here in the back, we find the opening towards the esophagus. The thing is that our trachea is always open because of the cartilages. The esophagus is always closed, only when food is arriving, the esophagus will open and the upper sphincter of the esophagus will open. So let's suppose we have a child with a CP that has a huge hyperextension of the head. This means anatomically that cervical spine is pushing on the very soft esophagus and it cannot open anymore, right? So whenever you have a child like this and you're feeding like this, you have to know that trachea is open, okay? Food can go very easily to the lungs, but esophagus closes. So when you change it and you get a proper alignment, food can go much easier to esophagus. We will see in our in our practical work how much of concern alignment and positioning is for our children. Swallowing is quick. Okay, so whenever I take a sip of my tea, you really need very, very proper coordination of movement, synchronization of movement. The thicker the liquid, the easier, right? The slower the bolus comes through your esophagus. So food like yogurt or thick creamy food or puree would be most easy for the children. Okay, so you will see what happens when a person eats 1 spoon of thick creamy food. Then you see that the bolus moves a little bit slower than water, tea, or very liquid juices, right? So very often we make a therapy program for our children connected to what is possible, what is easier to make steps for a child. Okay, start with something that is very thick, that looks like puree. It's much easier than water, right? Water very often is the biggest enemy of kids with dysphagia. So we get a lot of information from a modified barium swallowing study. So whenever we see that there is no bolus formation, we have a very slow oral phase, we have food going down before swallowing, right? So we have possible aspiration before swallowing. We have a very weak tongue, no proper mouth clearing. We have a tongue that is very tight. We have a very short frenulum. Then we have possible aspiration after swallowing. We have a diminished lift of the larynx and a diminished sphincter opening. Dysfunction of the tongue. Children with Down syndrome that have a very hypotone tongue, they have a very slow oral phase and possibly they aspirate. So in the pharyngeal phase is an involuntary phase, yes? Oral phase is the only voluntary phase, the phase we have a lot of control over. Pharyngeal phase we don't have any control, but the good thing is that the better you control your oral phase, the better the pharyngeal phase gets. So even kids with a severe problem in the pharyngeal phase will have benefit of feeding assessment and feeding therapy because we are influencing their oral phase and indirectly the pharyngeal and esophageal phase. So whenever we have a delayed swallow reflex, very often we have aspiration before swallow. Whenever we have a diminished lift of the hyoid and the larynx, we have aspiration during the swallow, or a diminished closure of our vocal folds, the last door that is closing, aspiration during swallowing. Food that is pooling, that food rests that stay in the pharynx, very often we have aspiration after swallowing. And then in terms of cricopharyngeal dysfunction, so achalasia of the sphincter, very often we have food rests in the oropharynx and aspiration after swallowing, right? So we use this tool a lot, especially in babies, especially in young children where endoscopy is very often not possible. So we have an idea of what is going on in the pharyngeal and esophageal phase. It allows us to apply, in the same time we're performing the modified barium swallowing studies, intervention techniques, and it will show us immediately if we have a proper idea of our intervention plan. So it enhances the safety of our patient and it prevents severe complications. Okay, I have some more time. Okay, so let's look at a video fluoroscopy, a modified barium swallowing study. Okay, so this would be a video fluoroscopy. It's 1 spoon of creamy food. Okay, so what we perceive here is that the bolus is everywhere. Food is everywhere. Food is in the mouth. Food is in the pharynx. Food is in the esophagus. Food is in the nose also. This is a child with Möbius syndrome. It's a double-sided facialis paresis. So this child has no control whatsoever over the swallowing. Okay, this doesn't happen in us. We have never food in our nose, right? We have never food everywhere. We form a bolus, we swallow, and the bolus goes down. So this is a very dangerous situation for the child. Okay, so what you can see here is that food is leaking towards the trachea. So we have some aspiration. And the thing is that this child doesn't even cough. So we don't have any sign from the outside that this child has troubles in swallowing. It tries, it tries, it tries. It's so weak in the face that it really can't. And then you see this hyperextension, right? It's trying with gravity to get some help, to keep the food in the mouth and to swallow it, okay? It's too weak to cough. So it has major aspiration, so it's very, very unsafe, okay? Whenever we change and we go into into flexion, things are better, but here we had major aspiration also. Okay, this is very liquid. And then we change it and we give a bolus that is thicker, so a creamy bolus. And then we see that we have a nice bolus, no whatsoever aspiration, so this would be very safe for the child. And this is how we started rehabilitation. You start from a starting point that is safe for a child. So for this child it was thicker food, pureed food, proper position of the head flexion, okay, and then slowly you build step by step the swallows. And the nice thing is that when you have one good swallow, it really teaches the next swallows. There is a learning process. Okay, so whenever you give safe swallowing to a child, we have a learning process of one swallow helping the other swallow. And this child was on a gastrostomy. Of course, feeding was very unsafe through the mouth, but within a year's time, we got this child off the tube, of the gastrostomy, and we rehabilitated full oral feeding. Okay, just to show you what unsafe feeding is all about, is okay, having the food in the mouth, okay, without even being able to elicit a swallowing reflex, having partly the food into the esophagus and the other part is going into the trachea. So this would be aspiration, right? Okay, so before the break, I would like to show you some videos of, I brought you many of our children. So very often this is how feeding intervention starts. It starts with, we use exactly the same material as you do. It starts with using a grabber, a bite block, okay, something that is very friendly in the mouth of a baby. This is a little boy with a gastrostomy, and we try to rehabilitate chewing function, swallowing function in a very friendly way. We try to get him into functioning of chewing, mobilizing, jaw mobilizing, bite, slowly, safely swallowing the saliva it has in its mouth, and then slowly going into small amounts of food. Okay, so first of all, what you use is empty spoons without any food. And we all know that you get exactly the same effect whenever we put a spoon in our mouth. What we do is swallow the saliva. So he does exactly the same. We give a very friendly spoon and we feed the child without any food, just dipping the spoon into a little bit of water, into a little bit of taste, right? Giving him an opportunity to swallow saliva. Okay, so this was a boy that was born prematurely, also with quite difficult respiratory function, with bronchopulmonary dysplasia, with gastrostomy inside for at least a year, and then he got rehabilitated to oral feeding. So very, very important in our intervention is safety, is pleasure, is trusting us. Never do something in feeding therapy that you did not decide upon together with your child. And I mean, even with very small children, you can tell them, okay, let's try this 2 times. Okay, 2 times is 2 times, not 5 times. Okay, so they really have to trust you and to build a relationship so that you can slowly build oral feeding with safety and a lot of pleasure. Okay, so using the pacifier for strength training, right? Hold it. So you try to enhance suction, lip closure. You even use it for chewing behavior. You can use it in different, okay, so in different functions. Very often you combine a lot of functions, right? Like in typical development, a lot of functions are occurring on the same time. Okay, and then one of the very nice things for oral stimulation, we will talk about this later in intervention, could be a toothbrush. Okay, toothbrush is very important because it's very important to have oral hygiene in children very, very early. Right, so whenever the first teeth arrive, you would like your child to brush the teeth. But it's also an excellent means of oral motor stimulation in the mouth. So we have a lot of swallowing the saliva, a lot of tactile proprioceptive stimulation in the mouth, in the oral area. So it's also very important that the child gets friendly with toothbrush and that it learns how to do it by himself. And I can assure you that it was not like this in the start, right? At the start it was quite difficult. Very often you have a huge oral defensiveness. in children. Okay, so this morning we talked a lot about typical development in eating. Just a little bit more about non-typical development of feeding, right? And what kind of populations do we have? We have CP, we have syndromes, myopathies. So all functions with eating and drinking are concerned. Different ages. We have babies, premature babies in incubators, newborns, toddlers, young children, even adolescents. I remember a boy once, 17 years of age, and it was a boy with a tetraplegia, CP, a spastic tetraplegia, a boy that was completely dependent from the care of the parents. And very suddenly, because of the hormonal changes, especially in boys, he had a drop of the larynx. So also the swallowing function changes dramatically, especially in adolescent boys. So his mom came to me and she said, okay, he's choking, he's aspirating, and doctor is proposing a gastrostomy for us. And she said, I'm so sorry, because this was our happy moments during the day. We're feeding, we're communicating. It was a child with multiple handicaps, very, very severely handicapped. And suddenly, even eating and drinking were taken away from this boy. Yes, it was not safe anymore. So we have a lot of things in our toolbox. So what we tried was functional rehabilitation plus neuromuscular electrical stimulation. So a little bit of surface electrodes and stimulation of the digaster muscle to get a proper elevation of the larynx. And I have to say that in 6 sessions, using the electrical stimulation plus a lot of functional training, we rehabilitated oral feeding, oral swallowing in a very safe and pleasurable way. Even the doctor would not believe that this function could be offered to this child again in a very safe way. So this is very important, to know what tools you have and to just know whenever to use what tool out of your toolbox. So just we have to stop at 10 o'clock, I think, for the break. Okay, so I have a quarter of an hour. Non-typical development of primary oral functions is all the functions that are connected to eating and drinking. Different ages, different types of problems, CP, syndromes, and this feeding swallowing disorder is referred to as pediatric dysphagia. So we can have a sucking problem, as in babies, like a transitional pattern or an immature pattern, like 3 to 5 sucks per burst, very little sucks, big breaks in babies, right? You can use oral motor assessment scales for very young children and babies, like the NOMAS is an old scale, but still used by scientists to develop different classification, right? Assessment of sucking movements for infants, and it's dividing infants into a big group of dysfunctional babies and disorganized babies. Dysfunctional babies, indicator of brain damage, early indicator of brain damage are the feeding problems. whenever we have big functional feeding problems in a baby, it's always an indicator to possible brain damage. So dysfunctional sucking would be abnormally wide opening of the mouth, no opening of the mouth, a lot of tongue thrusting, a lot of movements that are not particularly well coordinated for the movement, or absence of movement, asymmetry of movement, resulting in choking, gagging, aspiration, right? Feeding reflexes remain, so this dysfunctional sucking goes into dysfunctional feeding for many of our CP children or many of our children with syndromes, and they do not diminish, they do not go away, they strengthen as time goes by, so sucking doesn't change in quality. Transition to spoon feeding and chewing are very, very compromised. Disorganized sucking is the big group of premature babies that have a lot of problems in organizing their breathing with the technical issue of swallowing. So a lot of sensory aspects, a lot of tactile defensiveness, not able to sustain a normal mature sucking pattern. Very often this improves when you change the environment, when you go to a nice, quiet, dark bedroom, no noises, no music, no toys, no whatsoever optical stimulation. Then a baby wrapped around with a little blanket in a warm environment could perhaps perform a lot better. Just a little example. Just a couple of months ago, I was in Warsaw, Poland, and I saw two little babies, 2.5 months. They were twins, a boy and a girl. The girl was eating quite nicely, but every time at 40 milliliters, she would stop. So she would drink 40 milliliters perfectly, and then the rest of the bottle, like another 40, 50 milliliters, no way. What was the solution? This baby didn't like to have cold milk. A baby is able to distinguish a couple of degrees in the Celsius scale. So when the milk at the start is 33 degrees, 34 degrees, like our body temperature, it gets 29 degrees after 5-10 minutes, and then it would stop. So the solution was make 2 bottles, 1 bottle in the hot water and the other bottle feeding. So this was the solution. Okay, finished. Just 1 session. The boy was eating perfectly, but with the hairdryer. So we were in a hotel room, and mom was holding the boy. Father was having the hairdryer underneath, and it was making this noise. Bzzz. Okay, so you think, why? Okay, these kids were in the NICU, in the neonatal intensive care unit, for over a month. And this is what you hear in an intensive care unit. All day, 24 hours, every day you hear a noise like, it's like a white noise, okay? So that's why this boy was eating perfectly with the hairdryer. It was as if he was still in the incubator. So slowly, slowly, we have to give him a sensory diet of weaning off the hairdryer, right? There is a solution to everything, but you have to be able to think creative, right? Small kids, small problems. That's why we were talking about early intervention, and it's so important to intervene very early, because these two kids, I saw them last month. I met their father, and he told me, Dora, it's perfect. We are perfect. We are 7.5 months, and kids are thriving. We have no problems whatsoever in eating. So this is the best possible outcome you can have, right? Okay, this in connection to the disorganized group of babies that are very often preterm babies, and they lack a little bit in strength, and they have quite some oversensitivity, right? And sometimes they have a long period of time of tube feeding, especially if we have babies with severe problems like a heart problem or a respiratory problem or a very severe GI problem, and atresia of esophagus, or whatever, very severe problem, right? Respiratory distress syndromes, BPD, bronchopulmonary dysplasia. Then we have very abnormal synchronization. The only thing you have to do with those babies is 1, 2 sucks, bottle a little bit out. 1, 2 sucks, 1 breath. 1, 2 suck, bottle a little bit out. So this is a motor learning training for their respiration. They will pick up in a couple of weeks of times. You won't have any problem anymore, right? But you have to know what you're doing in the beginning. Abnormal muscle tone, hypertonia in the shoulder girdle, okay, so very often, shortening of neck muscles, resulting in bad lip closure, swallowing difficulties, danger of choking, changes of muscle tone in babies like hypertonicity, hypotonicity in the trunk, hypertonicity in the extremities, fluctuating muscle tones that is even much more difficult, like in children with athetosis or dystonia. And then sensory problems. It's always sensory motor problems, yes, but it's kids with a lot of hypo or hypersensitivity in the oral area, and this is compromising normal feeding. Oral area is a very important area, especially for a young child, especially in the first 2 years. Any abnormal sensory development in the oral area may cause very severe problems everywhere in the child, because the child is not secure anymore. The child does not recognize itself, does not recognize environment in a proper way. Okay, so I guess we have to, okay, just a little bit more. Non-typical development is showing everywhere, is showing in bottle feeding, is showing in spoon feeding. Very often parents will tell you, okay, Dore, it's not possible to go into spoon feeding. You saw this little boy this morning that for the first time in his life got a spoon with a little bit of fruit puree on it. He was eager to eat. He had a lot of pleasure. It was a new taste. It was something in his mouth that he didn't know, right? But he was not afraid. He wanted to participate. Many of our kids are afraid because they still have feeding reflexive, they are highly active, so they bite on the spoon, they don't have control over their movements, they gag very easily because their reflex is very prominent, and the tongue is not ready to take other food. Okay, so they experience this as something that is frightening. Cup drinking, for cup drinking, you need to control your breathing. So when feeding reflexes are still highly active, you don't have any respiratory control, cup drinking will be very difficult, right? And oral cavity does not control the liquid before swallowing. So as this sequence is not developing well, chewing, which is at the end of this sequence, will not develop. The children will have a kind of sucking behavior even on their solid food. We know this in our children. Tongue doesn't move the food to the lateral side. There is a lot of tongue thrusting, so they either lose the food outside their mouth or don't chew their food very well, so they swallow big pieces or choke even on big pieces. So there is a big lack of coordination in chewing and swallowing. There is a difference for kids with a lot of spasticity, for kids with a fluctuating muscle tone, for kids with hemiplegia, or kids with a very low tone, right? So when you have a very high muscle tone, especially in the oral area and in the shoulder girdle, you have a lack of lateral movements, of rotary movements, and high occurrence of active primitive feeding reflexes that don't go away. When you have a lot of hypotonicity, like Prader-Willi kids, like Down children kids, then you are strongly fixating somewhere. Some of these kids have a lot of bruxism, have a lot of grinding of their teeth. They very often tire out so easy. They have a big danger of being undernourished, and they have a severe developmental delay. Children with dystonia, with fluctuation of their muscle tone, is the most difficult group of kids with brain damage because of their never stable muscle tone. They can have abnormally large movements and extreme movements of the structures of their oral cavities. So very often they have a very huge compensatory mechanism of fixing in some other areas, like for instance their shoulder neck area. Kids with ataxia, okay, this very, very rarely happens without any other problems, very often after an operation, after removing a tumor in the brainstem, let's say. They have very slow movements, they have very low muscle tone, and they have a lack of protective reflexes, which is very, very dangerous. So they don't cough and they don't have a protective gag reflex. And then to end with, children with hemiplegia, they prefer their good side, but if we're talking about an oral cavity that is so small, when you prefer only your good side, okay, and you have a bad side, and this happens in a very, very small area, this means that both sides are affected equally. So they have a lack of symmetry, they develop a huge asymmetry and a huge oversensitivity. So thank you for this first part of my presentation. A little break.
You can have one or two questions.
First of all, welcome in Qatar. We are very pleased to have
Thank you
this
very much.
Information. You said that what is more challenging when we have behavior problems.
Yes.
I want to know how you manage that. Did you transfer for the psychologist, or is there any?
Okay. Sometimes yes. Sometimes yes. If behavioral problems are so big, then we encounter them with the help of a psychologist, of course, because of course we all know our limits. I am a speech therapist. I could handle with a sensory diet or even a behavioral diet, a behavioral feeding problem, but sometimes problems are bigger, are within families, are within bigger behaviors. So very often we call in a psychologist to prepare the family, to prepare the child, and to give us some advice about any behavioral problems. Yes. Thank you very much, because this is really happening in practice. Yes. Yes. Yes, please.
Thank you very much. أنا عربي ها؟
Okay.
You want to ask in Arabic?
If I have a translation, otherwise. Okay. Thank you.
أنا بنتي عمرها 2.5 سنين. حكوا لي إنه هي بنتي كثير بتحط الأشياء في تمها اللي لها رائحة. فيمكن هي اعتبروها إنه هي عندها مشكلة حسية جوا، ولا أنا أعتبرها مشكلة ولا لا؟ كيف بدي أحلها؟
Okay. And you mean, of course, that I think I will need it. Okay. Yes. And you mean, of course, that your daughter puts things in the mouth that is not food.
أيوة. Yes.
Yes. Okay, then a solution would be to make her a very good chewer, to make her interested in food that she can chew on, different tastes, different textures. This for sure would be on the intervention plan of a speech therapist. Very often this happens, that children put a lot of toys in the mouth, a lot of fingers in the mouth, and don't want any food. They are sensory-wise very defensive for food. Perhaps this is because she's a little bit afraid of food in the mouth and not choking, so she's defending herself. So I guess she needs a little bit more training in proper chewing, in proper processing her food. So then she will get less and less interested in putting a lot of toys in the mouth and a lot of things that she shouldn't put in her mouth that are perhaps even dangerous.
لا بس هي بتاكل كل شيء طبيعي، حتى الاشياء الصلبه يعني مثل الرز وهالاشياء كلها بتاكلها عادي. بس عندها مثلا زي المعجون، اي شيء له رائحه، قلم سبوره بتحطه في فمها.
Okay.
طفلتي داون سيندروم.
Okay. Yes. I believe that children with Down syndrome very often have a very big need of putting a lot of things in their mouth. Very often they are not very good chewers and they swallow quite big pieces. So you think that they are quite good and they eat their sandwich, they eat meat, they eat raw vegetables, but they don't chew very much. They just chew 1, 2, 3 times. That's enough, and they swallow big pieces. So she has to do some really proper, good chewing training. She's still very young. She's 2.5, you told me.
Yes.
So she's very young, and I think perhaps it's making contact with my microphone. Yes. So I think. Okay. So I think that she just needs, for me as a speech therapist, I would say that I would train with her a lot on proper processing her food and do a lot of chewing training to forbid her to put other things in the mouth. Sometimes it's not very nice. You cannot say no to her all the time because she's small. She's a girl or a boy? A girl, yes. So don't tell her no all the time. And if she would like to chew on something, you can tell her, okay, you can take your grabber and you can chew on your grabber, but you cannot chew on my pen because it's dangerous. Okay, try to give her a substitute. Yes, and okay, you can have a grabber with structure like this one that perhaps she would like because it's more interesting than just a plain one. Or you could even dip it in some fruit juice or some different tastes so that she gets a lot of taste, but she can do a chewing exercise also. Yes, it's different. It's difficult in the house because you need 20 eyes, not 2 eyes, because she's going everywhere and she will put everything in her mouth. So this is a very difficult period, but I think the only thing you could do with her is a lot of chewing training and giving her a substitute also. Yes. Thank you very much for sharing. Yes. Please.
Good morning.
Good morning.
I'm an occupational therapist. I'm working with visually impaired kids.
Yes.
Al-Noor Institute for Blind.
Yes.
Just as we hear in the first session,
Yes.
you said that it depends sometimes the operational feeding. It depends sometimes about environmental or sensorial facts.
Yes.
So just I want to add something that we experience it with our child,
Yes.
especially blind one. They have, sometimes we think that they have a sensorial problem,
Yes.
have the hypersensitivity or hyposensitivity in their mouth.
Yes.
But they don't have experience
Yes.
about some foods.
Yes.
Just trying hard foods
Yes.
or really smooth foods sometimes, they
Yes.
they are defensive about it.
Mhm.
But when we try with them a lot of times,
Mhm.
or as we use some facts, we use some installation, and it's okay with them.
Mhm.
Just they don't have experience.
Yes. Yes, you're very right. It's a very specific group of children. Children without vision or with visual impaired children, then you always have to talk to them and you always have to give subtitles. Okay, spoon is coming, you have some cream on your spoon, this is a carrot, it tastes like a carrot, and this is bread now. What do you want? Do you want a carrot or you want bread? Describe the taste, describe the food that goes into their mouth, yes. Very often our job is with CP children plus visual impairment. So this is, and then very often it's children with huge CP and visual impairment, so no communication, no verbal communication. We use Big Macs and we tell them, okay, today we have a croissant with chocolate and a pear. What do you want? Show me. Okay, I want pear. Okay, this is a pear. Yes, but it's very, very important to talk them through their meal. Yes, usually we don't do this, but with a visually impaired child, you have to do this. Otherwise, it will get sensory deprived because it's very frightening to have something in your mouth that you're not prepared for. Yes, it's like feeding another person blindfolded. Yes. So thank you very much for your add-on. Yes. Yes, sure.
We should start with the case.
Last question لأن أومي.
Last question?
Last question.
Last question?
Take this one. Because you speak Arabic.
Yes.
اوكي عندي طفله داون سندروم 13 سنه. كانت بتتكلم كويس جمل من 4 و5 كلمات متواصله. بعدين ركبنا لها التقويم. لما ركبت التقويم بدا ياثر عليها في الكلام. بقت تقطع الجمل، بتتجاهل الحروف وهي بتتكلم. في نفس الوقت خايفه انها تاكل، مش بتاكل زي الاول. فهل في تمارين او علاج حاجه معينه اعملها لها؟ شكرا.
Okay. Yes. Orthodontic treatment. Yes. In children with different muscle tone, with a deviation of muscle tone, like your daughter with Down syndrome, she has a lower muscle tone. Orthodontic treatment is difficult, very difficult, because mostly the differentiation in function or oral structure is because of the muscle tone. The muscle tone will not change, will always be the same, but you could change the function. So when your daughter had this orthodontic device, suddenly there was a dramatic change in her mouth. It was very difficult. Of course, the orthodontic surgeon tries to do the best for the occlusion of a child, because there might be a big problem in occlusion. But on the other hand, we as therapists, sometimes it's very difficult for us to handle a child with an orthodontic device or even after orthodontic prosthesis. So she needs, again, a little bit of refreshment of her speech therapy, because she was eating well, she was chewing well, she was talking very well. So I think with the new situation in her mouth, she again needs a little refresher therapy. Yes, it's a pity, but perhaps things will be much better, because now she has much better structure. So with a little bit of, and I think intensive treatment, she could be even much better than before. Yes, but now you have a little bit of downfall, you have a little bit, yes, I totally understand. You're welcome. Okay, so now we get our little friend. Oops. Okay, but he is interested in pictures, yes, I can see it. Okay, what's your name? Hello, hello. And now I'm so sorry that I don't speak your language. That's
His
difficult.
Name is Dia.
Dia.
Yes.
Dia. Okay.
When his hand moving around his eyes, he fearing and.
Okay. 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 Hi, Dia. You're a very nice boy. Okay. So I understand that Dia is 8. Yes. 8 years old. Okay. So first of all, we check facial expression. Yes. Which is nice. Okay. You're hearing a language that is very strange. Okay. It's very different. Okay. But you try to communicate with me. Okay. Very nice. Okay. You have a very nice smile. Yes.
ننزل فرشة ها؟ زين ضياء؟
Okay, so would you like to come with me to the mat? What do you think?
I told him already. يلا ننزل فرشة ضياء ها؟
I have some more. Okay. So, dear, let's get friends. Okay.
The trunk stability and control because she's severe spastic.
Yes.
Trunk control.
Yes. Is there any luxation?
Yes, compensate for trunk control to spasticity and
Yes. Okay. Okay. Right. So, what I already checked on is the facial expression. Okay. That is, of course, limited, but he has very nice communicative attitude, very nice eye contact. Yes. He's using his voice.
can
Okay.
understand the simple orders also.
Sure, I can see that. Okay. Also, breathing is very, very irregular. Okay, so let's move you to the side. Okay. Let's see. Okay. Okay. All right. Very nice. Okay.
He's fearing any change of voice.
Yes, yes, yes. You are a little bit afraid. Yes.
Can we turn them here?
And make a horizontal.
Okay, sure.
Horizontal, yes.
Like this. Oh, but it's okay. But it's okay. 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 So I will try to talk you through this, yes? So, okay. We're all here. Okay. Okay, so I will. But he wants you. So I need you next to me. Okay? Yes, yes, yes. Okay,
ضياء come.
good.
Yes. No, ضياء.
Okay, we can move to the side. Very nice. Okay,
Give me your.
very nice. Okay, so let's see a little bit.
شوف هون ضياء.
Okay,
ضياء عشان
very
نلعب لعبة ضياء.
good.
عشان نلعب لعبة ضياء.
Very good. We have to get acquainted a little, yes?
عشان نلعب لعبة
Very
ضياء.
nice. Okay, so what you feel is a lot of hypertonicity.
Yes.
A lot, a lot, a lot. Okay, okay. And there's a lot of hypertonicity going on in the shoulder area also.
ضياء.
Okay, so let's get this off a little. So I want to prepare him a little bit respiratory wise because he has very, very irregular breathing. Yes. Okay. So through a little bit of breathing intervention, I would like to get him on a more relaxed level. Okay, so use a little bit of vibration, resistance. Very nice. Okay. Mostly this is something that children like a lot. You want? Aha, I know. You like to touch hair. Yes. Good morning. Yeah. Okay, so what you do with your hands is feel the breathing. Okay. And on the exhalation, give a little bit of deep pressure and vibration. And then he gets calmer and calmer, because respiratory function is one of the basic functions. Dia? Ah, and your voices are getting louder and nicer. Very nice. Okay, so okay, let me be careful with your legs, because there is, yes, for sure, a little luxation. So Dia is a child that we were talking about, yes, with very low weight. Yes. Quite stiff. You're calling for somebody. Yes, for your friend. True. Okay. So there's a lot of stiffness, a lot of spasticity, but also a lot of fluctuating muscle tone.
This is assessment and intervention at the same time.
At the same time. It's never happening one apart from the other. When I would work with a boy like Dia, it would be assessing what my hands feel and then go into intervention. So I feel a respiratory function that is very irregular. Okay. So now it's much nicer. They're making pictures of you, so smile. Smile. Very good. Smile. Okay. Just in the break, we had a talk with my colleague, speech therapist, about the use of vibration. Okay. So with a boy like Dia, oh, you want a photographer. Okay, you like pictures. So with a child like Dia, deep pressure plus vibration could really help him lower the muscle tone. Okay. Okay. So same things that happen in his body are happening in the face also. It's a very stiff masseter muscle. Okay, so try to relax this with deep pressure and vibration. Okay, so that it feels much nicer for him and he gets. Okay, as I told you, muscle tone is never changing. Okay, it will always be dystonic, it will always be very high. but you can change the function. So if you get nicer voice, nicer swallowing, okay, then this is for Dia a learning process. Okay, you need time. Mm. 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 Okay. Mm. Ma. Mama, mama, mama. Na. Ayan. Nang, 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 nang. Eh. Eh. Ne. Ne. Ne means yes in Greek. Okay. Yes. Okay. So one of our jobs in speech therapy is having better voice. So it's very clear now that he has, okay, with a little bit of respiratory support that I was giving him, that suddenly more voices come. Yes, and nicer voices, like, okay, and then you can try to change. Ne, ne, di, 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 dia. Di, 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 dia. Di. Ah. Ah. Okay, so this is all a little preparatory work. Okay, so I can understand that, of course, Dia is eating his food by mouth, but that this is sometimes not very easy. Okay, let's sit. And now I have my microphones. It's not very easy. Okay, let's try. I will move. Okay, so extremely important for feeding is a sitting position. Can I use a chair? Oh. Can I use this chair? Yes? Okay.
This is.
Yes, it dropped. Please.
Sorry.
Yes.
Okay.
Okay, thank you. Okay. Aha, Dia, Dia. Okay, so let's see. Of course, Dia needs a proper chair, like he has, right? Yes, and also this chair that he has. Okay, it's for transporting, but it's nice. But what is important for... Okay, I just want to talk you through this, is having a position where pelvis is secure. Okay, I don't know about his hips, but there might be a luxation. But I don't think there is pain. Otherwise, he would have shown me. Okay, but the better his pelvis is, the nicer the sitting position. Okay, so what we would like for you is a sitting position with 90 degrees in your hips, 90 degrees in your pelvis, and then build on top of that a nice head control. Okay. So very often, as a speech therapist, you work a little bit preparing motor functions for Dia with a little bit of rotation, okay, with a little bit of shifting from side to side. Very nice. Very nice. Yes. Okay. Okay. So that's good. Right. So let's see what you would like. Okay, now we have to move a little bit towards. Could you help me? Okay, could you move my chair to the table? Yes, excuse me. Is this enough? Okay, very good. Okay, so let's see. Okay, we have a lot here. Okay, so let's see what we have. Yes, we have a lot of things. Okay, so, yes, sure. So normally, okay, we had this little blue, yes, because I would like to, okay. Are you hungry? Dia, would you like us to have some food? Okay, so let's try. This is your spoon. Right? This is your spoon. You want to try? Okay, so try first with an empty spoon. Okay. Okay. And here you see the strong influence of feeding reflexes that didn't go away. Right?
Can you rotate a little bit to no. The other side. Okay.
This side? Okay. So what is happening is we have a huge persistent bite reflex. Okay. Okay, and then sometimes Dia also has quite strong spasms where we have a huge raise of tone very suddenly. Okay, we try to move through this. Okay. Okay, use a little bit of rotation, very nice. Very good. Okay, I want Dia on my lap, not because I would feed him like this, but because I would like to feel him and I would like to know what I'm doing, right? Just, that's why. So let's try an empty cup. That's funny. There's nothing in. Nothing. Nothing. It's funny. Okay, you can just try. Bravo. And he's swallowing his saliva. That's very nice. Okay. So let's try. Okay. What would you like? Okay. Could somebody open? Thank you very much. Okay. It's mashed potatoes, yes. Okay. Okay, okay. Later. Later. Okay. Okay. Later. Later. Okay. No, thank you. Okay. So let's see, Dia. What do you want? What do you want? Do you want?
Cornflakes.
Do you want?
Cornflakes and mashed potato.
Okay.
The cornflakes is better for
Okay. Could you open? Okay. Very nice. We have cornflakes. Yes, and we have mashed potatoes. Very nice. So show me what you want. What do you want? Do you want cornflakes? Or do you want mashed potatoes?
شوف ضياء شوف تاخد cornflakes ها تاخد بطاطا ها بطاطا ولا كورن شوف تاخد ايه
Which one? What do you think? Patata.
cornflakes you can test
You say patata?
بطاطا
Batata. Okay, Greek is patata.
he can test first
Sure.
yeah
But in the end, it's all the same, yes? Yes. I have to tell them that they have Arabic roots. Yes. Okay, so let's see what we do. Cornflakes. Okay.
يلا افتح
Okay. Good. So we're going to move to his chair. Okay? Because it's, yes, the boy is.
you're a celebrity
Okay. Hi. Okay. His hips. First his hips.
Let me try just.
Yes. Okay. So
You can put it.
yes, very important is the hips.
Okay, that's. Yes.
Okay.
Yeah. Yeah.
I think it's together.
No.
Okay. Yeah.
That's
Separate.
separate.
Very good. Okay. Yes. Okay, so you want this angle, I guess. So what is very important now is where we are when we feed Dia. Okay, so when I would be here and I would feed him, Dia would constantly look at me or look at you, and we are too high because he is in hyperextension. So what we have to do is to find a very low chair, okay, or even be on the ground so that we have this connection, okay? Okay, this might be hard for us, but it's much better for him, right? Because you're really looking at me and you have a very nice alignment. Alignment, I told you in the morning, is very, very important for the safety of swallowing, and especially for a child like Dia. So whenever he sees you there, up there, you're too high. Okay, he makes huge hyperextension. So we have to come down. Yes. Okay. Yes, that's much better. Much better. Okay. Bravo. Okay. So let's try something. Do you like fruits? Yes. Wow, even strawberries and melon and kiwi. What's this? It smells very nice. It's very nice. Yes, what can I take for you? Okay, so let me try. Okay, just a little piece. Okay. So, instead of a safe feeder that is huge, that is too big, okay, we use something very small, okay, that's just tulle. Okay, you can try. Okay, let him just try. Okay, okay, he really likes to bite. Good. Okay. So instead of him having a bite reflex, yummy, yummy. It's good. Okay. Okay, it's okay. It's okay. Nice. Okay. 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 And then about wiping off. It's not dirty. Okay. It's never dirty. Okay, so when small kids try a piece of peach, a piece of mango, a piece of fruit, and okay, they're covered in juice all over. Okay, you can see that he likes trying. It's very safe. Okay, because okay, so in a way, it's okay. It's okay. You can use the bite reflex that he has. Okay, and slowly, slowly make it into chewing. Okay, okay. Very good.
Come like this for the video.
Yes. Okay, like this. Okay. Like here? Aha, aha.
Only for the
Okay. Okay. Okay, let's try again. Okay. You want to try more? Dia? You want to try more? Hum? Okay. Well, I think he's very good. Okay. So whenever a big bite reflex is happening, okay, we just wait. Okay, we just wait. It's part of a large spasm. Okay, never pull. Okay, just wait until it relaxes. Dia, 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 you want to try more? Very good. Very good. Very nice. Okay. 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 Okay, let's try something that you like. You like the cornflakes, yes? You want to try? You want to try with me? Okay, let's try from the other side. Can I? You want to try? It's cornflakes. Oops. Okay. Very good. Nice. Okay. It's good. Where do you want me to be? Like here? Okay. Okay. Dia. You want to try? Okay. You want to try with him?
Yeah.
Yes. You're feeding him?
Yeah.
Yes. Okay. So what are your problems in feeding him?
He catch on a spoon.
Yes. He's biting on the spoon.
Must be control his hand.
Yes.
يلا ديا افتح
Okay. Okay. Hammam.
يلا
Good.
ديا يلا اشوف 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 افتح افتح افتح
Bravo. nice.
Can make
Good.
some exercise for him.
Okay. To close the lips.
يلا ضياء أشوف. يلهم.
Okay. Yes, very, very important is alignment for Dia. That he is a little bit in flexion and never in hyperextension. Okay. Very nice, very nice. So being on his level is very, very important. Yes. And sometimes easing his posture through a little bit of vibration, deep pressure, as I did on the mat.
ضياء أشوف.
Okay. And then to be quick.
Oh.
Yes, to be quick so that he doesn't bite on the spoon and he catches the spoon. Yes. So the spoon you decided to use is very good. Yes, because it's a coated spoon and he will not hurt his teeth on the spoon. Yes.
We have little tooth here. We have here. You have little tooth.
Yes.
Okay?
Yes.
It come outside.
Yes. 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 Okay. Can I try a few spoons now? Okay, because of course, eating with another person is not very easy for Dia. Okay. So he has to feel safe with me also. Okay. Okay.
شوف فوق.
Okay. Okay. Very nice. Okay. It's not the best possible way to put the food behind his upper teeth. Yes, I would like to move the food to the side, but then I will have huge bite reflex. It will be very, very difficult. Okay.
He needs something more soft and tall.
Yes. Yes. Dia? Okay. So, let's make a summary. Dia? Dia?
يلا اكل شوف ضياء شوف يلا شوف
Okay. 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 About drinking.
You want hot water or juice?
I think a little bit of juice. Yes.
You can use shalom.
Yes.
Okay.
Thank you.
You want what?
I will try first with this one. Okay. Just some tissues, please. Thank you. Okay. Do you want to try? Dia? Okay. Try to get as much flexion if you can.
يلا اشوف يلا اشرب 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 عصير اشرب عصير.
Bravo. Yes. For sure, Dia's communicating and he tells me that he wants to drink. Okay. And he tells me that, yes, but liquids are not very easy. Yes. So I really think we should go into thicker liquids. So perhaps this is
or mango.
mango, so it's thickened. It's thicker. Yes. Okay, so let's try. Okay, so this is a honey bear bottle. Yes. It's very nice. Yes. And it's very helpful for children because with the valve, you can move really the liquid on top. When, okay, perhaps it's not a. Okay, yes, and it will stay there. Okay, so now a silicone straw would be nicer for. Okay, so what we could do is put it on the side. Nice.
يلا اشرب يلا شوف.
Very good.
فكرت في كده بس
Yes, 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 yes. 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 Thank you. It's okay. Okay. Do you want more? Okay. Okay. So what you try is to put it into the cheek.
ضياء يلا اشرب اشرب اشوف 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 اشوف.
Nice. Good. Okay. Okay, put it into the cheek and go with the liquid a little bit more backwards, and then with squeezing a little. Now he's drinking very quietly, not losing any liquid. Very good. Very good. Okay. Dia. More. For sure. Okay, let's try. Good. This session is a session of evaluation, of seeing what is possible for Dia, what is not. Okay, what is the safest way? For sure, he is very interested in eating. He's not at all afraid, although I think sometimes he might be aspirating, right? I don't know the history of his respiratory system. If he had any infections or any pneumonias, I hope not.
He's more all the time coughing.
Coughing, okay. So he needs protection, he needs safe things, so thickened liquids or thicker food like the cornflakes. Yes, more safe, yes. And then with a spoon, go quick. Be on the same level with him. You're eating with a whole amphitheater. You know that. It's very difficult. Okay, they're all watching you. You're very good. And then he's extremely communicative, even with me. And I don't speak his language. I can see that he almost trusts me to feed him, so that's incredible. And a nice thing is that afterwards I don't hear any wet voice, so that's very good. That means that he's able to swallow well, especially if the tone is more normal and he's not in a spasm. Yes.
His voice looks like a little voice.
Yes. That is dangerous. Yes. Yes, someone else is coming. Yes. Okay. Okay.
The focus treatment for him, what is the recommendation?
Okay, so could we take 10 minutes to talk about him?
Yeah,
yes.
Of course.
And perhaps 10 minutes is very little. Yes. Okay.
Yeah.
Bye. 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 See you. Dia.
He's interested.
Okay, give me your hand. Bye. High five. Very nice to meet you. You're a very cute boy. Okay, bye. Okay, you're welcome. Oh, now I have to manage mine.
Microphone.
You want to use like this, or you want to use it? I want to
Yes, I think we have to clean it. Yes. Okay, so let's just talk a little bit about what we just saw.
راح ناخذ تدريب عملي آخر. تدريب عملي آخر إن شاء الله ثاني، ونخلي البريك من 1:30 خلاص للثنتين، يعني خلاص يعني بريك ويطلع على طول. ناخذ المثال تطبيق العملي.
Tell me.
Other session for applying for other case.
Yes.
We take this break from 1:30 to
Okay, so can I take just 5 minutes to talk a little bit about this boy?
You will talk 5 minutes, they will bring the other.
Yes.
While you are talking.
Okay, very good. Okay, so this was mostly, I could say, an evaluation session and a little bit trying what is possible for this boy and what is difficult. Okay, Dia is a boy of 8. He has extremely strong fluctuations of his muscle tone. So it's hypertonicity, but it's also fluctuation of tone. He has dystonic spasms. So this makes eating and drinking not very easy, right? We have to make it safe for him. So for sure, use of thickened liquids and thick foods without a lot of pieces, like the cornflakes he's eating. If you want to try fruits or vegetables that are a little bit harder, only in a safe feeder, only this is possible. I would say that it would be very fit for Dia to use food in cloth or in a safe feeder, because he could enhance the quality of his bite reflex and get it into chewing. But then we have the dystonic spasms that make things very, very difficult. Okay. Oral feeding for Dia is not very easy, and you can see this in his kilos. I don't know what the weight is of this boy, but it was for me very easy to pick him up so I think he's about 11 kilos or something, and this is, or 15, okay. This is very, very little for his age. So here we have a big dilemma, right? It's a huge question. What to do? What is best possible care for Dia? I'm not a doctor, but I pose you the question. Okay, would it perhaps, but then I would have to evaluate much more careful with the caretaker how easy it is for the caretaker, how easy it is for the family to feed Dia orally. If the answer is, okay, it's extremely difficult for us to feed him, why not do combined feeding, like having a gastrostomy and oral feeding? Sometimes you say, okay, this is the biggest loss we could ever talk about. Yes, but sometimes it isn't. Sometimes it's much more human for Dia, for its family, for the caretakers, for the school he goes to, that he is properly fed with proper amount of calories. Then he will have a better health. And to think of combined feeding. But this is with big question mark, okay? We could never decide on this only with one evaluation session, with one feeding session. We would have to observe the caretakers, observe the family, okay, what is possible and what is not. But I have to tell you a personal experience. I once was with my very good friend Carolina, the physiotherapist that you had here for a course in Croatia, and we saw a boy like Dia, smaller, 4 years of age, with dystonia, with a lot of dystonic spasms, and a gastrostomy. And father of the child told me, Dore, this was the best possible solution for our family. We have 4 children, he is the youngest. We were feeding him 1 hour every meal, 5-6 times per day. So it was 5-6 hours of feeding our boy with a lot of problems. So here we have this combined feeling, and then a strange thing happens, that when I met this father 2 years onwards, two years later, he told me, listen, a very strange thing is happening. After we put the gastrostomy, and let's say 90% of the food was through the gastrostomy and 10% was by mouth, now we are almost opposite. We are 60-70% oral feeding and just a little bit of supplementary feeding through the gastrostomy. It's taking off the stress in families, in schools, for caretakers, for mom, for dad. It's something to think about, okay? I wouldn't like to put this especially on Dia. It's just a very kind boy, very communicative boy that, okay, I wanted to discuss this question with you and to open it on the table, yes, because it is happening, and we are able to take off a lot of stress, and then sometimes you do something very, very good, and then rehabilitation is much more easy for me as a speech therapist, for all of us as therapists. Okay, it's a difficult question, it's a difficult decision, but I want you to take it into consideration. I want you to. This is a little bit a lesson that we have to learn from some of our kids. Okay, so I need some time to go up to wash my hands and to see the next little patient.
They will leave. After a few minutes, they will leave. So we should see it now.
Okay, yeah, sure. Do you have any antiseptic? I think it's on. Okay. And you know it's heavy. It's okay. Okay. Oh. Okay, so the child is like this, and I will do it. Okay. Okay. Yes, yes. Sure. Okay. Yes. Uh-huh.
الكلمات وحاولي اسمع فيك شوي من هون وشوي من هون. يلا شوفي الجلسة تبعتها على اساس الواير قصير. لا هو بده واجع شوي. قربي اذنك فيك لهون. بس كلش هذا اخذ شوي هيك لقطات كذا.
This position for you is good.
Perfect. Okay. This is Yusuf. Yes? Yusuf. Okay.
That will be great. Right?
Good?
His hands like
Yes. Okay. Okay, okay. Okay. Well, hello. Oh, nice to meet you. Ah, you're all so happy kids. Yusuf? Ba. 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 Okay, nice to meet you. Give me your hand. Hi, hi. How are you? So many people today. Yusuf. Just look at them. Okay. Wait a minute. I will get my chair. Okay. So that's very good. So what's going on? School today? That's very strange. Oh, have you ever talked? A ball? Have you ever talked in English to somebody? Dee? Okay, give me your hand. Give me your hand. Hi, hi. Okay. 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 So we can see a lot of things about his oral cavity. Okay. Okay. Wow. Wow. You're talking a lot. Okay. So the occlusion is an open bite. Okay. Ay. Because of a lot of tongue thrusting. Okay, you see has wow. Oh my God, and it's all in my microphone, you know. You have a loud voice. Okay. So, Yusuf, you push with your tongue. Yes. That's why your teeth are a little bit open. Bye. Okay. Very good. Okay. So this kind of behavior, never, ever put a lot of restriction on this behavior. Okay. So if we talk about spoon feeding, you would never ever use a lot of pressure on the spoon with this kind of tongue. Okay? It would only make the pressure of his tongue fighting with me much bigger. So Aide? Did you say Aide? Okay. You see? Okay. You want us to try something? Okay. Let's see what I have. Let's see. Look. You know what this is? Boy. Okay, you can bite on it. You want to see? Do you want to feel? Just look at it. Aha. Yusuf. Yes. Okay, shall we try? Shall we try? Okay.
Good.
Okay. Okay. So, if you go to the side, tongue is inside. Okay. And then you go from one side to the other. Yes. So, solution for Yusuf is very different than the solution we would have for Dia. Okay. Okay. Well, you did some training. Okay. So he's chewing very nicely. So he could go easily to chewable foods. Yes. Avoid a lot of spoons that are in the middle of his tongue. That is very sensitive. Okay. Sides are very often much less sensitive.
But during feeding, how? During feeding, the spoon should be...
Yes. Okay, let's try something else. Okay, it's a new spoon. Okay. Look at it. Okay, try. Try. Look. You want to try? Okay, this is silicone. Look, look. You want to see? You want to see? Uh-huh. Okay. Okay. So what you would do is go to the sides with a spoon. Okay, like this. Okay. Never like this. Okay. Okay. Okay, so be on his level. It's not easy, yes? It's not easy for the caretakers. Hey, Yusuf, here. Here's my spoon. Okay. But if you go to the side, okay, and you use food that is not totally blended,
If we try in the middle, what happens?
he will push it out.
Push.
Yes. Yes. So we try? Okay, so let's see. What do you like?
But we can this bite for backing for the tongue when you use it to biting.
Okay.
training.
Okay.
It's
Yes.
Making backing the tongue already.
Yes.
practice.
Yes. Yes.
Yeah.
Yes.
What is
Okay.
pudding?
What is this?
Potato?
Yes.
Custard
Potato.
or potato?
Yes. No, it's potato. Okay. You want to try? Well, I think it's time for a little bit of potato. Yes. Good. Nice. Amin. Good. Okay, so a little bit more to the side, I would say, with him. Good. Okay, you could only do this with a softer spoon, right? Yes, so perhaps not with a harder spoon. Okay, and you're waiting with your tongue outside, yes, for the food, yes. You really like to eat, but okay, you're waiting in a wrong way. So feeding can go quite quick, but a little bit to the side. Okay, okay, this is perfect. Whoops. Okay, so let's see. Okay, let's see what happens with a little sandwich. Do you like? Thank you. Okay. So, okay, go to the side. It's an excellent chewer. Okay, and the thing is that you hold it outside, okay, and you try to keep the piece as long as possible on the side, okay. But it's incredible how he trusts me, okay. But you're very hungry, I think, yes? Or very interested in eating. Okay. Yes. Yes. And the thing is that Yusuf doesn't have these extreme dystonic spasms as Dia had, right? Okay. 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 Palate is very high. Okay, so what I do with the chewy tube, yes?
We need your advice regarding drooling for him, because he's only for drooling and in addition to the feeding.
Okay,
yeah,
okay, okay, okay. Okay, so biting, okay, and then going to the other side, right. Okay. What about drooling? Right? This is your big question. Okay. So, first of all, drooling is swallowing your saliva automatically. So this means that Yusuf should change his habit of a lot of tongue thrusting. So first of all, change the feeding habits. Go to the side with him with either solid foods or even spoon food, okay? That the tongue thrusting diminishes, because tongue thrusting really makes the mouth open and gives the open bite and doesn't really control drooling. Okay, so first things first is connected to his feeding. And then another thing is that you could use some facial taping to help him with swallowing saliva, right? This is like a 24-hour reminder underneath here. Okay, so tomorrow we will do applications of facial taping. It's a small eye strip, okay, with a little bit of stretch in the center. It's as if I would have my finger underneath. Boo, boo. Okay, so it would be like this facilitation. Okay, that gives him a lot of stability in the area. Okay, makes him react because the jaw is more stable. Okay. Gives him an ability of closing the lips, of using the tongue inside the mouth. Okay, so it's exactly the same as the facilitation we use for feeding. You could use it in this way also, right behind him. Okay, it's all about alignment, using proper alignment. Okay. Okay, so this facilitation in connection to, let's say, chewing could be very helpful. Okay, you don't want to bite on a chewing stick. I can see that. You want real food, but this as, okay, an exercise, going from one side to the other, so you make a simulation of chewing. Okay, is very good, with a little pause of, whoa, of swallowing, not of spitting. Okay. Okay, very, very good. So, about drooling, can come in severities. Okay, when it's very severe drooling, for sure the protective bib that he wears will be totally wet, which is wet. Yes, even hands will be wet. So it's, you're hungry. I know. So drooling is connected to proper feeding behavior, is connected to everyday feeding behavior. So if we behave enhancing the tongue working inside the mouth, we have done 70% of the work for drooling. And then on top of that, you do a small application of facial tape. And even for a short period of time, you could do a neuromuscular electrical stimulation with Yusuf. Okay, this is fit only for older children, adolescents, and adults. Is not fit for babies, for very small children. Okay, perhaps only in case of very severe myopathy or very severe facial nerve damage. Okay, and that would be the other 30%. Okay, but avoid the midline. Okay. Okay, so through daily handling, you will get much better movement. Okay, so this morning we were talking about the pleasure of feeding.
About 5 minutes.
5 minutes more. We will do as quick as possible. Yeah. Yes, because this boy is really showing you that he is so happy to be here, to be in this big audience, and to be totally at ease, because he really loves eating, right? So drooling, sometimes it's Botox, right? We could use Botox in very severe cases, okay? But it's not apart from feeding habits. It's not apart from proper dental care. It's not apart from proper toothbrushing, right? Okay, so do we have a toothbrush for him? because I wanted to show you something in connection to brushing the teeth. Okay.
This is a bit tricky. You can use it.
Okay.
Or you can use this one. This one, it's okay. Look like
Yes, I
Look
think
up,
I can.
but,
Yes,
look like
I think I can use this. Yes.
See?
Yes. Okay. Just some water. Okay. Do we have a cup? Okay, thank you. Okay. Okay. It's our new toothbrush. Okay. We will brush the teeth. Okay. So, toothbrushing is called therapeutical toothbrushing. Start on the sides. Oh. Very good, very funny. Yes, very funny toothbrush, but it's okay. I will tell you the sequence. So it's all about proper alignment. Okay, about proper alignment, about giving him the opportunity to close the mouth. Okay. To give him flexion. Oh, bravo! And to be able to either spit or swallow. Beautiful teeth. Beautiful. Very, very good. And some new teeth coming. Very good. And then what we do for just a little is go up to the ceiling, up to the palatum. Okay. Okay. No food on the palatum. Okay. Very good. So this is connected to drooling, right? To properly clean your teeth at least 2-3 times per day after each meal is not only for cleaning the teeth, it's also for having a habit of properly swallowing, using your tongue inside the mouth, closing the lips, breathing through your nose. Okay, okay. Yusuf will always have the tendency to push with his tongue forward. But if 5 times per day we give him opportunity to feel a lot of lateral stimulation through food, through toothbrushing, okay, he will slowly learn how to swallow the saliva better. And perhaps from a profound drooling problem, this will be a more lighter drooling problem. Okay, we have to be realistic. We were talking about SMART goals, yes? So goal for Yusuf, for me, would be to go from profound drooling to a more medium drooling, okay? Where he would wet only his chin. Okay, Very, very good. You want the applause? Okay, listen. Yusuf, do you want an applause of everybody? Do you want? Listen. Wow! It's for you. It's for you. Yes, you're the big star. Okay. Okay. Does he have any alternative communication?
With his dialect?
With any alternative communication
with him? With
yes.
him? Yeah, he uses devices?
Yes.
I
guess.
Yeah,
okay.
because he has good...
yes, he is. Yes. Very good. Very nice meeting you. Okay.
The best, Yusuf?
Nice meeting you. Okay.
Yeah.
Good. Thank you.
Hello, thank you for the nice practical.
Hello. Yes, it's not very easy, you know, with such big audience. Okay, but
First time with the case.
okay.
Yeah, I want to ask about the first case.
Yes.
Would
Yes.
you recommend going for a modified variant study for him?
Sure.
Yeah.
Sure.
So,
Yes.
what made you?
There is a couple of red flags that were occurring in my mind while feeding Dia. Like his voice quality sometimes is changing. He coughs, especially in thin liquids. I'm sure in thin liquids that he has a minor problem, a minor aspiration, yes. I would perform a modified barium swallowing study just to know what is most safe for him. Yes, yes.
Thank you.
Yes, you're welcome. But I think we all know the answer. I think the answer for Dia is in a safe way of feeding, like thickened liquids, straw drinking with a straw on the side, and then using a straw that is a silicone straw that he can bite on but not totally destroy. Yes. And then food that is quite easy, okay? And if you want to give him, like Yusuf, more solid food, then put it into a safe feeder, for sure, yes. And perhaps not the juicy fruit that I gave him, because it's a lot of juice, a lot of thin liquid, and this causes a lot of problems, yes. So more food like cheese or bread or thicker food without a lot of juices. Yes, yes. You're welcome, yes.
Hello. Yeah.
Okay.
Thank you for your engaging session. This is regarding Yusuf, the second child.
Yes.
How many meals in a day we should go for him? And the amount of food should be equal for all the session, or we should have a more meal in the more amount of food in the initial session.
Okay,
so
that's a very nice question, and I think we will give the answer tomorrow in the feeding intervention that we will do. But very often you look at what is possible for a child. So with Yusuf, I think it's quite easy to give him the calories he needs, and he's a very quick eater. He's very trained, very skilled. You really feel that he did a lot of good work. With some other kids, like Dia, it's much more difficult. So I would say make smaller quantities of food with a lot of calories inside. We can make, a dietitian could make 100 milliliter small bowl of food with the same amount of calories like a 250 milliliter bowl of food. So I would go for clever solutions. And then in Dia, I suppose that we have reflux. also, for sure, a kid with this kind of dystonic spasms and hypotonicity in the trunk and hypertonicity in the other regions, in extremities. So then you decide to do a lot of smaller feedings, like even 6 or 7 small feedings per day. Yes. Thank you for the question.
Salam.
Okay.
Yes, I have a student. It's 10 years. He's 10 years old.
Yes.
He swallows food without showing it.
Okay.
What we do with him.
Okay.
Is putting foods in one side.
Okay.
And make chewing exercise.
Yes.
There is more that we can do for him.
Yes. So it's no use to swallow big pieces of food.
No, he can swallow.
Yes, he can swallow, but he's not chewing very well. Yes. So when a child is not chewing very well and he swallows bigger pieces of food, this is bad practice, because big pieces come into the stomach. The stomach has to work very, very hard, a lot of acids to digest these big pieces. So a lot of chance of more reflux. So for a child that swallows big pieces and is not chewing very right, you have to do practice like I did now with Yusuf. So put on the side, control the chewing, control that he at least chews 8-10 times on one piece of food, on meat, on vegetables, on fruit, that he really chews them. And if it's not possible like this, put it in, say, feeder. Okay, and do a lot of training with chewing. Otherwise, we don't give big pieces. Only controlled feeding with solids. Yes. Yes.
Some people say that oral motor exercise,
yes,
exercise make drooling increase.
Make drooling increase. Okay, then they do the wrong kind of oral motor exercise. It's true. It's true.
Some people tell us that some doctors say this words.
Okay, listen. Oral motor exercise is functional exercise for something. You never do oral motor exercise because you like oral motor exercise. When you do oral motor exercise program for drooling, then you do a functional program for drooling, like I would do with Yusuf. I would go into chewing, into biting, into giving him a break for swallowing, into therapeutical toothbrushing, into stimulate the mouth and mobilize the mouth and strengthen the mouth with a functional goal for drooling. So if you would say that oral motor exercise increases the drooling, then the therapist is doing the wrong things. This can happen. This can happen because, you know, there are a lot of things. Okay, manufacturers like ARC, like Talk Tools, you have all their things, make a lot of things, but it's for us to decide what to use. Okay, so perhaps if you use vibration on a child that is with huge hypotonicity, then it will drool, of course, more. It will increase the drooling. But if you use deep pressure and vibration on a child that is extremely hypertone, you will do the best possible thing for this child. So everything is with a functional goal. Yes. Sometimes you have to try again and again. And sometimes I tell myself, okay, Dore, this is not working. So do something else. This is what I told you this morning. Evaluation is never one time in all our children. every time with Dia, every time with Yusuf, I would be evaluating and reschedule my program. Yes. Thanks for the question. Very good question.
Assalamu alaikum. You are welcome here in Qatar.
Salam alaikum. Alaikum salam. Yes, yes. Thank you very much.
Thank you. I have two questions. One about barium swallow.
Mm-hmm.
Who decide that the child need barium swallow procedure?
Okay.
Because it's investigation for the upper tract of digestive system, I think.
Yes.
Until the beginning of the intestine.
Yes.
The second thing, what the problem affect the result of barium swallow,
Mm-hmm.
and if there is any precautions.
Mm-hmm.
Second question about feeding a tube. We know that some child have pulmonary disease need to use feeding a tube.
Mm-hmm.
What the side effect of using feeding a tube?
Okay. Oh, difficult questions, yes. Okay, let's start with the first. So modified barium swallowing study is always prescribed by a doctor. But as a therapist dealing with pediatric dysphagia, you could mention to a doctor, give him a report like, okay, in Dia, I saw wet voice, I saw a cough, I see some vomiting, I see very difficult respiratory behavior. We realize that he has very often recurrent infections. Would you please consider a modified barium swallowing study? This is the way it goes in Greece, and then a doctor will say, of course, because my report is right. When my report is, okay, this child is chewing big pieces, then the doctor would say, okay, stop using big pieces, or make when it's only the oral phase, then it's not needed to do a barium swallowing study. Yes, so he would not admit this child for a swallowing study. So it's also through our reports that doctors have guidance, because yes, they never have the time to sit with a family and to really do a session like we do now for 1 hour, let's say. Yes. And then your second question about tube feeding, about side effects of barium, yes?
About side effects
I don't know. Yes.
How it affect
okay. Yes. Okay, so when we have a nasogastric tube for longer than, let's say, 6 months, we get a dependency on the nasogastric tube. So then we have to be very careful. And if our prognosis as a therapist is that we will need for quite a long time tube feeding, and rehabilitation of oral feeding is very difficult, then perhaps we better decide to put a gastrostomy. And this is happening very early now. So when I have a baby of 6-7 months and it's fed with a nasogastric tube, and I tell the doctor, okay, I need more time. I need a couple of months. I need 4, 5, 6 months more for rehabilitation. Then it's a proper practice to put a gastrostomy to totally disconnect this area from all the traumatic experiences of putting a tube. Okay, taking off a tube is very easy, but putting a tube is very hard for a baby. So then we do a very early gastrostomy for a small time, for 4 months, and then you have rehabilitation much quicker. So there is a protocol. In America, there's a stricter protocol.
Can we help the child during he using the tubing, the feed, the tube?
Sure.
Tube?
Sure.
Can we help him by any exercise?
Sure. Sure. You do the full intervention program. Of course. Okay, it depends on the safety. Okay, so every child with a tube, of course, has had a modified barium swallowing study, because it's a child that is aspirating or a child with huge swallowing problems. So we have to know what is safe for this child. So when thick yogurt or puree is safe for this child, then you could decide to start your intervention program with this material. Yes, but of course you start with tube in place, even with children with a tracheostoma. Okay, even with children with tracheostoma and tube.
Thank you.
You start. You're very welcome. Yes. Ahmed, there is another question. Ladies first.
Excuse me. Okay, I have just one question.
Where are you?
Here.
Okay. Okay.
What are the benefits of putting child in vibration?
Yes.
When feeding.
Okay.
When feeding the child.
Mm-hmm.
And in which area we use these benefits? In which area?
Okay. In our children with CP, I would be very, very reluctant with the use of vibration. Many times it is of use with children that have behavioral or a sensory problem. So with children with autism or children with a combined multiple handicap of autism spectrum and CP, you could use vibration like a vibrating spoon, right? They suddenly get very interested because this stimulus, we don't know a lot about vibration. This is a stimulus that is still in full research. What is happening and what is the frequency of the vibration? This also, and what is the acoustic effect of vibration? Because all electric toothbrushes have a lot of vibration, but also a lot of acoustic stimuli also. So it's difficult for me to say when to use and when not to use. I would be very, very careful with kids with huge hypotonicity, because they will fall into big hypotonicity and even bigger. So perhaps a use in a child like Dia that is of huge hypertonicity. Yes, this is what I used with my hands, but with your hands you use a vibration that is very low frequency and without any acoustic stimulus. So this is the nice thing of using your hands on the outside. Okay, you cannot use it on the inside, but only on the outside of the face and for the breathing on the trunk. Yes. So only for kids with huge hypertonicity, I would say. Yes. Yes.
I want to ask about the children with autism.
Mm-hmm.
Let's say they don't have problem in sucking and drinking the juice.
Yeah.
They don't have problem in eating the sandwich.
Yes.
But there is drooling.
Okay.
So that's
Okay. There is drooling.
It's not a very. It's a medium drooling. It's not.
Yes.
It is not permanent.
Yes. Yes.
And
Yes.
that's the challenge.
Okay. Okay. Yes. Behavior.
Because I am a mother of autism child.
Okay. Okay.
He's
Okay.
doing as I know, I am medical background.
Yes.
Medical background.
Mm.
And I am a mother of a child with autism
Mhm.
and genetic disorder. His
Okay.
genetic disorder, he make him hypotonic and lapse.
Okay.
So
Okay.
he's doing drooling, he mean it, I notice. For 6 months he will leave this behavior.
Yes.
If he wants to attract you for more attention, he will do drooling,
Okay.
or squeams for his eyes,
Mhm.
or doing sounding for his non-verbal.
Okay.
So I am thinking the autism child, most of them they are behavioral, not.
Okay. Drooling is something very strange because it comes and goes. It's fluctuating.
And he's not showing
Yes.
probably actually.
Okay.
He's because he's hypotonic. Everything
Okay.
is lax and low and slow.
Okay.
So he prefers
Okay.
to swallow the food.
Okay.
I use the same as you are using, but I am not
Yes.
in 24 hours.
Mm.
You know, he's with caregivers. I am working.
Yes,
so
sure.
I always encourage the caregivers to put the food, especially start with dates.
Yes.
And with it because dates is
That's
sticky.
very nice with
Yeah.
dried fruit, like
Dried
your
fruit,
dates. It's
yes.
perfect
Banana,
consistency.
on the sides, here and here.
Yes.
And try to crunchy things also.
Yes.
Biscuits to let him feel the sounds. Maybe
Yes.
to-
How
and
old
he
is
improved.
How old
He's
is
9
he?
years. 9 years.
9 years.
He
Okay.
improved a lot. Alhamdulillah, he's
Okay.
improving.
Also, he is in a period where he finishes with all the teeth.
He didn't change. He changed only two.
The kinanes
Yeah,
is
the
yes.
one-
So he is in a period where the mouth is on fire.
Yes.
And this is a very difficult period for children anyway. Okay, all kids. They start drooling when they lose their front teeth. So they are 6 or 7, and suddenly you see saliva loss in all kids. So I think.
What I noticed also on him
Yes.
that he doesn't like the toothbrush.
Okay.
If you are up apart teeth, no problem. But if you will go down for the down, he's irritated, and I try to
Okay.
not to harm him. And I'm using different types
Of brush.
I use the vibrates, little vibrate.
Okay.
I'm
Okay.
trying,
Like a
but
sonic
even
brush.
Sponge, even the lemon
Yes.
swabs. And sometimes I'm using for him to let him try to tolerate this. I think he has something in sensation in the lower
Mhm.
limb. Yeah, maybe.
Okay, okay. This is a big question because then we have to talk about. Yes.
He's in Shafallah.
Okay.
Today he didn't come. Tomorrow
Okay,
tomorrow
for
he
sure,
comes.
for sure. We can see him together, but you're talking about tactile stimulation, about tactile information. When you use cotton swab or when you use this, this.
Yeah, that's sponge, I think.
Yes, a sponge.
No,
Okay.
that's softer. It is
Yes.
glycerin with lemon salt.
Okay. Then we're
they are using usually for ICU patients.
okay, but then we're talking about very big tactile stimulation because the lighter the touch, the stronger the stimulation. When you go with a feather on your cheek, it's the biggest tactile stimulation you could ever give. When you go like this on a cheek. Yes. So you better use a silicone brush when the gums are very irritated because new teeth are coming. So use a silicone brush, but brush quick and firm, not slow and, you know, with a very soft device. That's more irritating than a stronger one. Yes. Okay, so it's many things. It's new teeth coming, and perhaps it's also behavioral. So in this period of time, you could give him, you should have a lot of lemons and oranges. Give him acid juices. Yes, because okay, you have a lot of saliva, but swallowing is really stimulated with a sour taste. So better swallowing. But we can talk when we see your boy together tomorrow. Yes, it will be my pleasure. Yes.
Hi. Assalamu alaikum. That if the child have aspiration all the time, what's the procedures or the protocol I should take? There is any procedure or protocol I should make it if the child has aspiration. Feeding all the time. I go good alignment and I do all the stimulation.
Okay. And still you have aspiration.
She has aspiration and changing of color of her face. It's become blue and red then blue. So it's a danger situation. So what is the procedure or the protocol I should take to become in the safe side?
Yes, to be safe, because we yes. You are a therapist. Yes, physiotherapist. We have to protect ourselves as therapists because this is a basic vital function that has some dangers. So when our child is aspirating, for sure, sometime it will have a major pneumonia. Perhaps not immediately, but the lungs are taking food inside, and suddenly this will become a problem and it will become a huge infection. So, yes, it's an aspiration pneumonia. So this can be extremely dangerous for a child. So that is, then it is bad practice to feed this child and to know that there is a chance of pneumonia. So I think this is not our task, but it's the doctor's task to make a decision for this child to be able to safely get calories. Okay, for us, the only thing we would like to do with a child is provide safe and pleasurable stimuli for feeding. When it's not safe, okay, then we have to report it to the doctor, and we have to tell him, okay, this child is aspirating a lot. What are we going to do? Are you helping me with a gastrostomy so that I can slowly give this child and rehabilitate without quantity, without the use? Because, you know, this was happening 15 years ago with babies. Nurses in hospitals, in the NICU, were focused on quantity. 50 milliliter, the baby goes home. So they were forcing the baby to drink 50 milliliter. It's possible because we are much stronger than a child is. But it was malpractice because then after some time, this child has huge behavioral feeding problems. And it has a dysphagia and it has a behavioral problem. So that's why in the morning I told you it's worse. So with your child, I would say that this is bad practice to feed a child and to see that your child has aspiration, and that for sure at some time you will have a pneumonia that could be very, very dangerous. Yes. So it's a doctor's decision, but you have to know what to do, and the parents have to know about the risk and the safety of the child. Yes. But when a child is turning blue or changing color, this is an indication of oxygen saturation that is going down. So this is a very bad situation, very bad. Yes.
I have a student 14 years old.
During feeding section, she refused and she catch anything near here. Okay, and I cannot control. I cannot control to hand because she catch everything. Okay, how I make during the section? How I get the food if she refuse and catch everything near here.
Okay. Okay, it's very nice questions because it's real questions and it's real children. A month ago, I had the same kind of presentation in another country, and we had this little boy with CP, autism, also mental retardation, and parents told me, okay, he is 13, he is eating very nicely with a DVD in front of him, but not without a DVD. Yes, and the question was of the school personnel and of the therapist, what can we do for this boy? And they were trying. A physiotherapist was holding his hands. Another one was strapping him to the wheelchair. It was a horrible situation to see. And then somebody was feeding him and he was denying the food. And then I said, okay, this is not ethical. We have to see that this child is 13, he's used to eating with a DVD, so let's try something else. And we darkened the room, we put the DVD screen in front of him, so we made it like a little film, like there was no distraction, only the DVD, and immediately his behavior changed. It was more a behavioral issue than a technical issue. So what you could do with a child like this is try to get into his mind and what is making him easy, what is making him accepting, and then try little by little to have some changes, but not something very different from his home situation. Is this answering your question, or is it a different child?
She have problem behavior.
Mm-hmm.
If I have a system to catch the student, is this okay or not okay?
Okay, what you also could do is give her a spoon, empty spoon, give her an empty spoon to do whatever he likes. She refuses. Okay, then if she catches the spoon, you put your hand on top of hers and you eat together. Is it possible?
But maybe she's not hungry.
Okay, she obviously. Okay. Okay. Yes. 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 Could you try to eat together with her? So, no, it's very difficult. Okay. Give her something in her hands that makes her occupied. Is it possible?
She have a problem in behavior.
She has a problem?
If I come here, if I
okay. Sure.
لما اجي اكلها وهي وانا جنبها هي بترفض، وبعدين كمان هي بتمسك اي شيء جنبها، يعني هي المشكله مشكله سلوكيه، يعني هي بترفض الاكل بصعوبه. ان انا يعني مثلا لما اجي اعطيها مثلا الاكل هي بترفض ان هي تفتح open her mouth. اوكي
Mhm.
فيها مشكله لو انا مثلا خليت مثلا او حطيت لها حزام مثلا او على ايديها او خليت حد يمسكها
Yeah.
فيها مشكله.
Okay, okay. I would say this is the last thing you would do. I wouldn't do this. Yes, I would never strap her. But I would deprive her from a lot of stimulation. I would put her in a very dark room, with a screen in front of her. In this case, I would use a tablet. You know, many kids nowadays, typical development, are eating with a cell phone, are eating with a tablet, are eating in front of the television. I would make a very deprived situation, like very dark room, one screen, and you are feeding her. Try.
Or maybe the food, the girl, she is not hungry at that time.
Maybe the girl is not hungry.
Yeah, maybe the food time smell doesn't like if she has autism. Maybe the food itself, she doesn't like the...
Okay, maybe the child doesn't like the food. Maybe she's not hungry. Is there any...
You can keep her calm by open music and
Okay.
some attractive...
Okay, yes, maybe change a stimuli, like seeing a DVD with children's songs, or just to get her, yes. Okay, yes, I wouldn't strap her. Yes, that's not nice. Yes, but I understand that you have a huge practical problem, yes? Yes, so try to get her interested in the DVD, to get her distracted, make it a very dark room, and try to feed her, try to see what she likes also, what tastes she likes most. Okay, is she reacting to every food like this? To everything? Severe mentally retarded, yes. Okay. Yes, then it's a question of how to feed. Okay, then again, it's a medical question of, is it human to strap this child and to force feed? I don't think so. So this is a big question. You would like to be with the gastroenterologist, with the surgeon, with the pediatrician on the same table, and to tell him, listen, this is my child. If I don't strap my child, I can't feed my child. I have to force feed him. Is this good practice? Or do we have to search for a different solution? So maybe a gastrostomy is much more human for this child. And then just keep the things that it really likes by mouth, that it can really enjoy. Okay, big questions you have, big issues. Yes, please.
Good afternoon.
Good afternoon.
I would like to ask which one is more difficult during feeding therapy? Fluctuating muscle tone, severe hypertonia, or hypotonia?
I would choose the first one.
And why?
And I'm sure, you know, because many kids I had in my hands, yes? So when you have a muscle tone that goes up and down, like Dia, okay, is on the high level, on hypertonia level, but it's going up and down, and it's going into dystonic spasms that are on the ceiling, that are so hard, and they last a long time in Dia, okay? They last about 30 seconds, and then he relaxes, and many times it's even longer. And when he has a very tonic bite reflex, then there's a tonic spasm coming and a dystonic spasm coming. and it lasts long. So for sure, these children have less control than a child that is with spasticity, like Yusuf, or a child with hypotonicity. Then a child knows that, okay, I'm always stiff, tense, I'm always low tone. But a child that is up and down, you're never sure. Yes. So for sure it's the first. Yes. Yes, you're welcome.
Yes, hello again. Me here.
Yes, yes.
I want to ask about the functional electrical stimulation
Yes.
for the drooling problem with
Yes.
yourself.
Yes.
I want to know who's responsible for conducting this intervention in your facility.
Okay.
And if possible tomorrow, you can show us some video.
Aha. Okay, well, for sure I have some pictures. I don't know if I have video with me. But responsible for using these superficial electrodes is the therapist, is the speech therapist. There is two contraindications. This is mostly for adults that have a pacemaker for heart disease, so then you have a contraindication. Or if you have a cancer that is still malignant and active. Yes, so also kids that had a tumor operated and they still have remains of the tumor active in their brain or in central nervous system, then it's contraindication. You can't use. Yes, but it's very, very nice to use on facialis paresis. It's very, very good to use for older children with drooling problem. Then you do a very intensive training of, let's say, 4 or 5 weeks of electrical stimulation, facial taping, and all the other oral motor intervention, oral motor stimulation techniques that we will talk about tomorrow. So sometimes this combination of things is very, very nice. Yes. Like this little boy, really, we rehabilitated oral feeding in about 6-7 sessions. So this was huge success. Yes. So I will search this afternoon if I have any film, but for sure I have pictures of kids. Yes, you're welcome.
Hi.
Yes?
Yeah.
Yes?
Just as what we understand and know that about the question it was now, not this one, the one before, that we have to collect as a data collect about all factors, environmental, positioning, medical, like
everything.
If we can talk, it is like ABA techniques,
yeah.
The factor before and within and after
yeah.
This activity, and we check.
Yeah, that's true. And you check every time, and sometimes you just find something that works.
Try to
yes.
be interdisciplinary.
Of course, because when it's going into behavioral, very often we use the knowledge of a psychologist, or when it's more into sensory, we use the knowledge of an occupational therapist that knows much more about a sensory diet than we do. Or when it's a problem like DIA, where we have possibly a subluxation or a luxation, okay, how to position this child? You need to work together with the physiotherapist. Sure, true.
Good afternoon. We have case I want to talk about it. When we want to feed her, she have two problems, bite reflex and tongue thrust.
Mm-hmm.
If we make his head forwardly, slight flexion. She can control her jaw slightly and
Yeah.
open,
Yeah.
and the bite reflex is too much increased.
Yeah.
But the problem here is starting tongue thrust. He will push the food. She will push the food up.
Yeah.
If we release her head, she will be in not good position.
Yes.
She will tilt
Her head backward.
But tongue thrust here eliminates.
Yes.
She can swallow.
Yes. Yes.
How
Yes.
can we
Yes.
manage this?
Yes. Yes.
There is risk, but alhamdulillah.
Yes, 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 yes. What would be good is putting the food on the right place. Like with little Dia, we tried with a straw to go in the cheek. So the straw was in the cheek, quite far behind, and then I squeezed little by little by little, and then he was able to slowly, slowly, sip by sip, drink this liquid very nicely without losing it. So you could put the food on the side, but quite far inside the mouth, so that you don't lose it and you keep the flexion, because it's so dangerous to swallow with hyperextension. This is really very, very dangerous. Yes, and the older our kids get, the stronger they get, and the stronger the primitive reflexes get. So the bigger the problem gets for them. Yes, that's true. Welcome. Yes, please.
I think for the gastrostomy,
yes,
we have to work hard on the awareness.
Yes.
Because a lot of parents, they refuse.
Yes. Yes. Yes.
And we have the
Yes.
experience here.
Yes.
One mother, she said, I will not make a gastrostomy.
No,
Even
no.
I let him die, and we will not
Yes.
make for him a gastrostomy. So we have to work hard on the awareness, especially between parents.
Okay.
That they have the experience for the gastrostomy.
Yes. You opened a big discussion. We have exactly the same discussion in Greece. It's Mediterranean people. They are fond of eating. They really are fond, much more. I can compare with people from Holland and Greece. They have very, very different opinion about food. Okay, the Dutch people, they eat, finished. Okay, Greek people love to communicate, to eat for hours, and okay, it's a much bigger issue. So when you tell a mother your kid needs a gastrostomy, it's like telling the mother, you're not a good mother. You cannot feed your child. And this is horrible. I can believe the feelings, and I think it's the worst feeling for a mother or a father not to be able to feed their child. So this is a discussion that we often do with a psychologist, but we have to make a true discussion. We have to put it on the table, and then when the parents decide we won't have a gastrostomy, this is our decision, we don't, then we have to decide, okay, what is the safest way for these parents with their child, so that we have the least possible side effects like severe pneumonias. But you are right that it's a very difficult discussion, and sometimes parents like to keep the nasogastric tube and not go to a gastrostomy. And then I tell them, but this is inhuman and this is more human. But okay, then if I tell them, okay, it will be for a small time, not forever, but it will make my work much easier. Okay, this is a discussion that you have to make with mutual trust. Yes, and you have to take time for this discussion and to hear the parents and to really listen to them, because this is big problem. Yes, this is not small. Yes, that's true. Okay, so this is so very nice, you know. I would have the same interaction in Greece as I have with you, and this is telling me again and again that we have a lot in common. So thank you very, very much for all these questions. It was really nice, really nice. Thank you, thank you.